Hi, Katie, this is Amy. Oh, we're gonna. Katie, can you hear me? Maybe she's not there yet. Hi, Katie, can you hear us? Hey there? The good thing is I can hear myself. So I know that when you take yourself off mute, they'll hear you. You can mute yourself again if you want.
Hi, Katie, can you hear us? I think you're muted. Hi, Katie, can you hear us? She's offline.
I emailed her.
Okay.
Keep getting confused because there's a Karen Robinson.
Oh,
They all say offline. maybe
They
that's
do?
because they're not part of Sodexo, would
Right,
be my guess.
okay. But if she were on, she would say something.
Amy, Susan, can you hear me now?
Yes, we can.
Well, how about that? It must have just been my phone. I had you connected to my iPod, but I'll use my
Okay.
computer speakers if that's okay.
Yes.
That's
you
fine, we can hear you.
Loud and clear.
Great. All right. Nothing like a little last minute stress.
No, that's okay. Just so you know, Susan will start with an intro and I'm going to have this screen up. And then once it's your turn to go, feel free to just take over the screen by sharing your presentation.
Excellent.
And yeah.
Leave it on when she's
Yep,
done.
and then leave it on when you're done. And Susan will go through a Q&A about your presentation before we move on to the next speaker.
Wonderful. Sounds great. Sorry for the voice today.
Oh,
Oh,
that's all
that's
right.
Hopefully you can still understand.
Yeah. All right, I'm going to admit everybody in about.
And then Susan and Amy, before you admit everyone, is it possible to get a list of all the attendees? Usually I have them sign into the chat box for these programs just so I can make sure for CE credit, we
Yes.
have that.
Yes.
Yes.
Then-
Yeah.
Okay, great.
So
I-
so I have the sign up list and then I will also extract the attendance list from the participants on the Teams meeting.
Wonderful. Thank you so much.
Yep.
Sure. Good afternoon, everyone, and welcome to our 8th annual Advances in Clinical Nutrition Symposium. My name is Susan George, and I'm the Clinical Nutrition Manager with Sodexo at the ProMedica Health System. We have an exciting lineup of speakers again this afternoon, and it is my privilege to be hosting this symposium today. We have an audience of over 200 participants joining us this afternoon. The symposium will provide 4 CEUs for registered dietitians and 2 CEUs for RNs, and that'll be for the first 2 topics that are being presented. Before we get started, I would like to go over a few housekeeping rules and reminders. The audience will be muted during the entire symposium. The chat feature has been disabled, but please feel free to ask questions through the Q&A after each presentation, as we will have a brief time for questions. There will also be a 5-minute break after the second speaker. And lastly, an evaluation form and CE certificates will be mailed out to all participants the day after the event. Our first speaker this afternoon is Dr. Katie Robinson, who will be speaking on adult malnutrition screening, assessment, and nutrition interventions. And this is a timely topic because this week is actually Malnutrition Awareness Week through Aspen. So looking forward to hearing Katie's talk. Dr. Robinson serves as a medical science liaison with the Adult Therapeutic Medical Science Liaison Team at Abbott Nutrition. Prior to joining Abbott, she conducted research on the impact of nutrition and genetics on outcomes of behavioral and surgical weight loss interventions. Dr. Robinson completed her bachelor's degree in dietetics at Iowa State University and her dietetic internship at the University of Illinois in Urbana-Champaign. She earned her Master of Public Health and doctorate in Nutritional Sciences in the Illinois Transdisciplinary Obesity Prevention Program. Her graduate research sought to understand how pre-op dietary interventions and individual genetic variation contribute to improved insulin sensitivity following bariatric surgery. During her time at UIUC, she taught multiple undergrad and graduate courses and assisted with coordinating undergrad didactic program in dietetics. Following graduate school, Dr. Robinson completed postdoctoral training at the University of Iowa in the Fraternal Order of the Eagles Diabetes Research Center. Dr. Robinson has numerous publications in peer-reviewed journals and has presented her research at national and international conferences. Please join me in welcoming Dr. Katie Robinson.
Hello, everyone. Sorry about that little issue there. Hopefully you can see my slides. I am so excited to be here to talk to you about adult malnutrition. Also apologize for the voice. I promise it sounds worse than it feels. So I'll try to make sure it's clear today so you can understand everything about that I'm going to share with you about this very important topic. We're going to talk through screening, assessment, and nutrition interventions. As a disclosure, today's program is meant for CE credit for both dietitians and nurses. So you'll get 1 CE credit for my part of the presentation today. That means that it has been evaluated to ensure it's evidence-based, fair and balanced, and non-promotional in nature. This educational event is sponsored by Abbott Nutrition Health Institute, which is a non-branded educational platform that may be used by dietitians and nurses to review different CE materials and also training infographics, training materials, podcasts on all things nutrition. And then finally, as was stated, I am an employee within scientific and medical affairs at Abbott Nutrition. The objectives for today are to discuss validated screening tools for adult malnutrition. We will talk about assessment as well, primarily focusing on the clinical characteristics from the Academy, as well as Aspen, the American Society for Parenteral and Enteral Nutrition. And then finally, we'll wrap it up by discussing best practices for nutrition interventions. These are the recommended readings for today. As you can see, that White et al. Paper in the first bullet point are the clinical characteristics from ASPEN, the Academy. Now, these are also being more common or more recently referred to as the AIM criteria, the ASPEN and Academy Adult Indicators for Malnutrition. But I also want to make you aware that there are other assessment strategies that you may choose to use. Specifically, one that we hear about recently is the GLIM criteria, the Global Leadership Initiative in Malnutrition, which is in the second bullet point in case you're interested in learning more about those criteria. Now, I want you to pause to think about your patients. I'd like to ask you, what % of your patient population at admission has malnutrition? When we look to the recent evidence, you can see here cited in that first box, it's estimated that anywhere from 30 to 55% of hospitals are malnourished upon admission. In the second box, you see that unfortunately, many patients experience nutritional decline during the hospital stay. So this study, as well as a more recent study, found that about a third of patients, regardless of if they were malnourished or well-nourished at baseline, experience nutritional decline in the form of weight loss. So start to think about why this might be. What happens during the hospital stay that might lead to weight loss? Well, you might be thinking NPO status, or patients are fasted for a long period of time, or maybe they're not fed adequately, right? They don't receive adequate nutrition. They're also sick. You might be saying they've got inflammation, hypermetabolism. It's very difficult to meet their calorie needs. And we also see that sometimes tube feeding, for example, may be turned off for various reasons. Maybe you've seen this if a patient's being repositioned, or maybe if the tube gets dislodged. Many reasons account for why a patient might experience nutritional decline in the hospital. And then when it comes time to discharge, of course, some of you may not always see what happens to a patient after discharge, but when we look at the literature, for example, a study out of Canada found that about 26% of patients that were discharged lost 5 pounds or more in the month after discharge. So it's possible that for some of these patients, they may already be malnourished, experience nutritional decline during the stay, and then continue to lose weight when they go home. And as you can imagine, this places them at higher risk for things like readmissions, poor quality of life, complications, and a higher risk for mortality when we look at observational studies. So this is why it's so important for our patients with malnutrition that we're aligning our efforts on how we define malnutrition. And this all starts off with screening. You can see here on the decision-making table on the screen. The first box is the screening question. So we just figure out if a patient's at nutrition risk during screening. And this can be done by a registered dietitian, but it also is maybe more oftenly in the hospital setting done by our nursing staff or maybe nursing assistants. So at admission, we're asking questions like, have you lost weight intentionally? If so, how much? And have you had changes in your dietary intake? So what screening tools are you using for this? And if I had the chat box feature, I might ask you to just share with me. But one screening tool you may be using is the malnutrition screening tool. And this is, you can see here a list of different validated screening tools. And I say the MST because this is one that had a position paper more recently from the Academy that said that this could be used regardless of the patient population you work with, their age, or their medical history. Now, there are others listed here that you may choose to use that have been validated in different cohorts, such as the MUST tool. Nutrition risk screening tool is also one that we see endorsed by ASPEN. Regardless of which tool you use, you just want to make sure you're using one that's validated in your patient population. And here's just an image of the MST. In case you're not familiar, you can see that it's 2.5 questions. And this should help to inform you as to whether if a patient would benefit from an assessment with a registered dietitian. Ideally, if they score a 2 or greater on the MST, they do see a dietitian for that full nutrition assessment. Now, getting back to our decision-making tree, you can see that the next question we ask is whether or not inflammation is present. And the reason we ask this is because it can help us to tease out what might be the underlying cause or etiology of that malnutrition. Is it related to starvation? Then potentially inflammation isn't the underlying driver. So starvation or social environmental is the first. Then we also have chronic disease and acute disease where inflammation may be contributing to the underlying changes in body composition that you're seeing. Now, with inflammation, the question always arises of how do we determine whether it's inflammation? Well, maybe you're looking at those classical signs of redness, swelling, heat, and pain. Maybe you're looking at labs. So, for example, a CRP value that might be elevated. Also, you may be looking at their problem list. So does a patient have things like advanced cancer or cancer cachexia that we have seen in the literature is associated with inflammation? The other thing that's interesting to know about inflammation is not only can it help us tease out what's the underlying etiology, but maybe it also helps us to understand some of the other labs that we're pulling on these patients and whether they're still relevant to nutrition status. So of course, as you'd expect, this brings up the question of albumin and prealbumin being used as nutritional markers. Because as you can see on this slide, with inflammation, the validity of some of those different markers that maybe we've traditionally relied on is called into question. Because with inflammation, of course, your body is prioritizing different acute phase proteins. So those positive acute phase proteins seem to go up in circulation. So we see an increase in antibodies, the complement cascade, TNF-alpha, IL-6, those proteins that are associated with the immune response. Makes a lot of sense, right? There's inflammation, your body's reacting to it. But what that means is that there's also a reduction in other proteins. So these negative acute phase proteins, such as albumin, transferrin, prealbumin, retinol binding protein, these can decrease in the face of inflammation, regardless of what we do nutritionally. So that is why albumin, prealbumin, not great markers of nutrition status, especially in the face of inflammation. If you are still having a lot of consults for albumin, one wonderful paper is the first citation on this slide, which was written by Dr. David Evans, who is a physician, and he wrote this along with others from Aspen in order to address this misconception. And there's some wonderful quotes in there. We've just pulled out one here, just really reiterating based on the evidence, albumin and prealbumin should not serve as proxy measures of total body protein, muscle mass, or nutrition markers. All right, let's get back to the etiology. So we've talked about screening patients, looking for whether or not we believe there's inflammation in order to help tease out what might be the underlying cause of the malnutrition. And when we talk about cause or etiology, we think of three. So the first is starvation-related malnutrition. So start to think about what patients come to mind. This is typically caused by social environmental factors. It is chronic in nature, so it takes a while for this type of malnutrition to occur. It wouldn't just occur in days to weeks, it's typically months to years. So we think of maybe a patient with poor food access. So maybe you're thinking of patients with homelessness or who have food insecurity. Maybe you're thinking of cognitive dysfunction. So maybe you're thinking of your patients with eating disorders, right? Anorexia is often described as a starvation-related malnutrition. Different physical impairments. So maybe you're thinking of dysphagia, poor dentation of the teeth, maybe dementia, could also fit under this type or this etiology of malnutrition. The next is chronic disease-related malnutrition. This is driven by a mild to moderate level of inflammation. When we say chronic, we typically mean 3 months or longer. And some examples here are listed on the screen. When I ask this question to groups when I'm live rather than virtual, I often hear, well, I immediately think of my patients with cancer. And that makes a lot of sense, right? Cancer is a chronic disease that can exacerbate loss of lean mass and fat mass. So we think about the tumor itself could be releasing proteolysis-inducing factor or lipolysis-inducing factor, right? And breaking down those stored energy sources or protein sources at an exaggerated rate than what we would see with simple starvation, right? May also be exacerbated by the treatments, radiation, chemotherapy, and so on. So cancer is one that always comes to mind, but also think about your patients with COPD, with congestive heart failure, maybe even your patients with diabetes or obesity, right? So this, of course, is not just held within one BMI category. It can be seen across the BMI ranges when we start to think about sarcopenia, loss of lean mass, even at high BMIs. And then the final etiology that you would select from when you're writing your nutrition diagnosis for malnutrition is acute disease or injury-related malnutrition. So the patient here that comes to mind is that patient with severe inflammation, so very high levels of CRP, for example. There's typically an acute onset, known duration of this injury. So we think of patients with sepsis, traumatic brain injury, acute respiratory distress syndrome, maybe your trauma patients or your burn patients. Think about how those needs can change rapidly and also how quickly lean body mass can be lost in this situation, right? You've seen that patient who is admitted, who is sedated and intubated. And so that loss of lean body mass can be quite exaggerated, right, in this patient population. So those are your three etiologies. You start to think about this as you go in for your assessment, right? But what you also need to gather is the data, the clinical characteristics to support that nutrition diagnosis. And you can see the 6 listed here on the screen. I think many of you are familiar with these. So that's insufficient energy intake, unintentional weight loss, subcutaneous fat loss, muscle loss, fluid accumulation, and declining functional status. And if you have 2 or more of these, that is appropriate support for a nutrition diagnosis of malnutrition, which then, of course, would need to be shared with the rest of the healthcare team so that an appropriate provider or clinician can provide a medical diagnosis. Now, the first with dietary intake, I don't spend a whole lot of time here because I do know many on the line are dietitians, and you're very familiar with how to collect a dietary recall and compare that to a patient's estimated energy needs or energy requirements. And that can, of course, be calculated using a weight-based equation, or maybe you're lucky enough to have indirect calorimetry and you could actually measure it. The slide here is just a reminder to us that when we look at the clinical characteristics, the degree of restriction in calories is related to the degree of malnutrition we suspect. So more moderate deficiencies in calories, you can see in the orange bar here, are related to more moderate malnutrition, versus the kind of magenta color there. You can see these are more severe restrictions in intake, meaning for example, acute disease or injury-related malnutrition. If a patient is consuming less than 50% of their estimated energy requirement for greater than or equal to 5 days, that's, of course, a more severe degree of restriction than maybe if they're consuming less than 75% of their needs. So these characteristics just try to help guide us. But of course, you're going to need to use your clinical judgment, especially when patients fall between these moderate and severe cutoff values that are provided by Aspen and the Academy. Weight is another one. I just have one slide on because we know how to look at a weight history and start to tease out what might be normal for this patient and try to look for more details as to when this weight loss started and what might have initiated that weight loss. This slide just shows you how the cutoffs for what's moderate weight loss or moderate level of weight loss associated with moderate malnutrition and what's considered more severe. So as you can see here, one thing that's always interesting to point out is how the duration varies based on which etiology you suspect, right? So with a chronic disease or starvation, social environmental malnutrition, that weight loss occurs over a month, 3 months, 6 months, a year. Whereas in acute disease or trauma, this can be a shorter period, right? I mean, they even have criteria for weight loss during a week. Of course, these cutoffs are meant to be guidance. And so there are patients who may fall between that you just want to use your clinical judgment on to determine whether that is moderate or severe malnutrition. And you just want to make sure you're documenting your rationale in your notes so that that's clear to the rest of the healthcare team how you came to the conclusion that this patient either had moderate or severe malnutrition. All right, let's jump into the hands-on nutrition-focused physical exam, and I'll try to do some demonstrations. I'm not sure I can get my leg up here to show you the assessment of the leg, but where I can demonstrate, I'll try to demonstrate, and feel free to practice along at home. So as we assess the orbital region, the triceps, and also the thoracic lumbar region. If there's a mild degree of depletion in these areas, that may suggest more moderate malnutrition, whereas if it's moderate or severe, depending on the etiology, that might suggest more severe malnutrition. So the images we have here, I only have an hour with you. Sometimes we have more images, but the ones that we selected to show you here are from the Veterans Health Administration. And what's nice about them is they do show the trajectory of what this area would look like if the patient had a normal status in that area, be it subcutaneous fat or muscle, versus a mild to moderate loss or severe loss. And what you can see here is the first one is the orbital fat pad. So you'd want to assess this. If a patient had glasses, we'd have them take their glasses off. And we'd want to assess this straight on. So you're going to use your 2 fingers to palpate underneath the eye, sometimes up and around underneath, around the whole orbital region, right? Because that orbital fat pad should surround and protect the eye. But it can become depleted, right, with increasing malnutrition. And so a severely hollow, sunken eyes, dark circles, loose, saggy skin that's not age appropriate. This would all be ways that we describe severe malnutrition. And you can see some demonstration here in the image. Next, we have the triceps. And so for this, you're going to bend your arm up at a 90-degree angle, or your patient's arm. Hold the patient's hand so that their arm is just relaxing, and then use your free hand to basically pinch and roll the skin on the back of the arm, not the tricep. So you may choose to activate, right? So you can feel where their muscle is, because we want the skin, not the muscle. Because we're looking for subcutaneous fat, right? And what I like about this image here is it's a cross section of the patient's arm, and then the assessor's hand, right, is feeling it. So what you see in pink is the skin, in yellow is the subcutaneous fat, and in red is the triceps muscle. So what you also see is how close the fingers can get together as the patient becomes more depleted of the adipose tissue underneath the skin. So with severe malnutrition, there will be very little space between your fingers. Your fingers are nearly touching. Whereas with normal, maybe that's more ample, that ample fat tissue. And then finally, we have thoracic lumbar. For this assessment, we're going to have our patients either sit up, or if you're fortunate enough to be able to have the patient stand up and press against a wall, that's an option as well. If they're sitting, you have them sit up, arms straight out. You use your hand to kind of press against their hand and position their shoulder in the right place, right? And then you'd use your free hand to press down the mid-axillary line, which runs from the middle of the armpit down to the hip. And what you're feeling for there is for how much your fingers are falling between the ribs, right? Are the ribs protruding and prominent? Because of course, with ample fat tissue, we wouldn't be able to feel the ribs as well, or they certainly wouldn't feel protruding and prominent, because there's this layer of adipose tissue that should make this area appear more full. And you're also feeling all the way down to the iliac crest, right? So across the hip bone, how protruding and prominent is the iliac crest to help us determine if that fat mass has been depleted. Okay, so those are the 3 areas for fat loss. You may also choose to assess other areas. I know I've heard people use the buccal fat pad right here underneath the cheekbone is another alternative. But again, I'm just sticking to what was described in the White et al. Paper. All right, next we have muscle loss. So you can see there are many regions where we're looking for muscle loss. Mild loss would be related more to moderate malnutrition in these areas, and moderate to severe loss is related more to severe malnutrition, of course, depending on the etiology. So first we'll start with the temporalis. And with the temporalis, you're going to use your fingers in a cross-type motion across this temporalis muscle here. It's a seashell shaped muscle that helps us bite down. So if you bite, you should be able to feel that activate there. Normally this should be kind of well-defined, either flat or maybe even slightly bulged to the touch. But with increasing malnutrition, all the muscles are atrophying, right? Because you're using the protein stores for other reasons. So this can become slightly depressed. And then with severe malnutrition, this could be described as severe hollowing or scooping, or severe scooping and depressions of the temporalis. So it's good to look at the patient straight on, because sometimes you can see that scooping of the temporalis as you look at the patient straight in the eyes. Next, we have the clavicle. So with the clavicle, if you've got a hospital gown on, great time to kind of pop open the buttons and feel for the clavicle bone above and below. You're using your fingertips to palpate over the top and bottom, feeling again for the muscle development, not just the bone, but the muscle development around the bone structure. With normal amounts of muscle, the clavicle may protrude slightly, but there'll be no area of maybe depression behind the bone, right? So as you feel over the top. Whereas as that patient becomes more severely malnourished, the clavicle is going to appear more protruding and prominent because of the atrophy of muscle over that area. From here, we go out to the acromion process. So the bone, straight follow your clavicle all the way out to the acromion process, and then over the deltoid with your full hand. Feeling for the curvature. So we want to consider, what does the curvature look like as we go down the neck, out the shoulder, and down the arm? And also how round and what's the tone of that deltoid. So you may choose to have them activate, but of course, importantly, we want to assess it in a relaxed position. We don't want any flexing. With severe malnutrition, the bones will appear more prominent. The shoulder will look more squared off, and the acromion process can be more visible. You can see that here in the top are the computer-generated images, and then the bottom, these are real pictures of older adults with that matching level of muscle loss. Next, we go to the back. So same position as when we were assessing the mid-axillary line for subcutaneous fat. You're pressing against that patient's hand and assessing the back, or you're having them stand and push against the wall. And what we're looking for in the back is basically running your hands over the spine, the ribs, the scapula to feel for muscle development. With increasing atrophy of muscle, as you might expect, the bone structure is going to feel more prominent and protruding. So prominent protruding spine, scapula, ribs in these patients with more severe malnutrition. And then from here, we were already pressing against their hand, right? We can just go ahead and have them relax their elbow down and make the OK sign with their hands, feeling for depression of the interosseous. So you'll also, with increasing malnutrition, be losing muscle in the hands. And so this might feel more depressed as you palpate this area between the index finger and the thumb. And then finally, we have the legs. So we do want to assess for muscle development in the legs. And we do this while the patient is either sitting with their leg at a 90-degree angle, or they can be in a bed if you prop that leg up to a 90-degree angle. And you're feeling for the patella, so the kneecap, the quadriceps, and also the gastrocnemius, the calf muscle. And these pictures, although not in the right position, right, because our patient's standing, their leg is straight, ideally these would be bent, but you still get an idea of how with severe malnutrition, the patella looks more protruding and prominent because all the muscles around that kneecap have started to atrophy. And so you can see not only the patella is more prominent and protruding, but there's also all these kind of greater, you notice here, more curvature around the outside of the kneecap. The knee can also be the widest or more wide part of the leg in general, especially as we start to look at the thigh, which also, as you'd expect, increasing atrophy, we're going to lose some of the muscle in these areas. So rather than being these nice, well-rounded muscle bellies, we see very thin atrophy of the upper thigh as well as the calf. So you're feeling for the thigh, and then obviously in that 90-degree angle, we want them not to flex their calf. You may choose to have them activate it to make sure that you're feeling for the muscle, right, in that leg, not the fat maybe surrounding it. But what we'd like to see is a well-developed round bulb of calf muscle. But unfortunately, as you can see in the image, that muscle is going to become more thin and close to the bone with increasing atrophy. And you also, I love this image because of the kneecap. If we look at how the knee becomes more protruding and prominent, right? It's almost lifted out of the knee, or excuse me, out of the leg with increasing loss of muscle. All right, so that was the hands-on nutrition-focused physical assessment and all the different areas we're going to want to consider for subcutaneous fat and muscle loss. There are two other criteria that I wanted to review with you before moving into interventions, and those are fluid accumulation and declining functional status. So fluid accumulation is the presence of edema, and typically this is not the direct manifestation of malnutrition. So it can be caused by other things. Of course, you've probably seen it in your patients with chronic kidney disease or chronic liver disease. Maybe you've seen it in patients with CHF. So there are other conditions that might be contributing to the presence of edema. It can, of course, be the result of malnutrition if we think about very severe protein restrictions, but here in the States, it's more often caused by something else. Why edema is important to consider is because it can mask weight loss, right? If a patient has a large amount of edema and fluid at different areas of the body, you may not be able to get an accurate weight on that patient. And you may also not be able to do the hands-on nutrition-focused physical exam to the same sensitivity as you would in a patient who did not have a large amount of edema. So it can be used as a criteria if it's mild edema, would mask a mild amount of weight loss, so it could be used for moderate malnutrition. And if it's moderate to severe, depending on the etiology, it may be used as a criteria for severe malnutrition. Now, it is important to note that your nursing staff is likely collecting this data already. I do show one example of what's considered mild, like a 1+ edema, and that's dependent on so when you assess for edema, you look over a bony prominence, so maybe the top, the shin or the top of the foot, and you're going to basically press in, see how deep your finger indents, and then when you release, you're looking for how quickly it refills. You can see in the table here that the deeper you can push into the fluid and the longer it takes for it to refill, the more severe the edema. There are slightly different criteria for edema, so you just want to make sure if you're assessing this, if you're not the nurse, right, if you're the dietitian, you just want to make sure you're aligned with the nursing staff and that you're assessing in the same way. And some of you may even choose to look at the nursing notes to collect that data. All right, next we have functional status, and this is the last criteria, and this is one that the recommended technique for functional status is hand grip strength. So I'm not sure how many of you have hand grip dynamometers, but it's basically this tool that you hold in your hand and you have your patient squeeze it in order to show how many pounds or kilograms of pressure their hand can apply. Of course, the positioning is very important in this assessment. But the thought is that by the time a patient has developed functional declines in their hand grip strength, and that is measurably reduced, that has become pretty severe malnutrition. So it is currently only used as a criteria for severe malnutrition rather than moderate malnutrition. Okay. We reviewed the 6 criteria. A call out that, of course, I kind of mentioned this already. There are patients who are can be a little bit more challenging to do the nutrition-focused physical exam on. For example, patients with obesity may be more challenging to look at the abdomen and the torso or the legs. And so you may choose to focus more on loss in the face, so in the temporalis, the orbital fat pad. Maybe they're also showing weight loss more significantly in the clavicle or the deltoid region. And then with critically ill patients, there may be certain challenges that you have here, right? Positioning is always tough in a patient. Obviously, if you can't get them to sit up, it's not going to be appropriate for you to look at all of the different areas that we discussed. So if you need to skip different areas, you just want to make sure that you're documenting, I couldn't assess this because of patient positioning or maybe their stability status, whatever it might be. You just want to document it so that the next dietitian in line knows it's not that it wasn't a problem. It's just that I couldn't assess it because of the patient's critically ill status or maybe tubes, lines, things in the way. And then a call out too that I mentioned, we talked solely about the Aspen Academy criteria, but there are other assessment tools out there. Some of you may be looking at GLIM criteria, for example, the Global Leadership Initiative in Malnutrition for diagnosing malnutrition. And what you see here is that there's actually some overlap in there's slight differences, but there's some overlap. So they also recommend with the GLIM criteria that screening be conducted first, and then that the patient be assessed, looking for phenotypic criteria and etiologic criteria. And what you need is one of each. So for phenotypic criteria, maybe that's unintended weight loss. Well, that's also in common with the Aspen Academy criteria. They also have reduced muscle mass as a phenotypic criteria that you could select from, which is also in the hands-on nutrition-focused physical exam. And then if you switch to etiologic criteria, reduced food intake is one of their causal or etiologic criteria that may be used in GLIM. The difference here, of course, is that low BMI call out, not as much of a focus here in the Academy Aspen criterion. This might be related, of course, that our patient population does have a higher risk for obesity here in the US. So maybe that low BMI category isn't quite as relevant here as it may be globally. And then also for etiologic, there is a focus here on disease burden and inflammatory condition. That is not one of the clinical characteristics for Aspen and the Academy. So there's slight differences, but both are under validation currently. So there's studies going on to look at the validity of these different criteria in identifying malnutrition. And then just one other call out I want to make. We focus on adult indicators for malnutrition, but I, of course, want to share that there are pediatric indicators as well. This slide just serves as a summary of some of the key differences. And most importantly on this slide is the citations, right? So that you can go back and check out citation number 2 and 3 which identify and talk you through the different characteristics for identifying pediatric malnutrition. All right, let's put it all together and let's run through a quick case study. So this is your patient. This is a 54-year-old male presenting to the ER 7 days ago with abdominal pain, complaints of nausea, cramping, vomiting for a week. They were admitted on hospital day 1, status post-appendectomy with infected abscess that turned septic, and so they were transferred to the ICU on post-op day 3. The patient reports that they've consumed about 25 to 30% of intake from most meals in the past week due to poor appetite, nausea, and vomiting. You can see here their previous medical history, their labs, as well as their height, weight, and usual body weight. So based on the screening tool you have at your institution, would this patient be referred to see a registered dietitian for assessment? I hope your answer is yes, right? We've got some risk factors here, including changes in appetite that are pretty significant. So you go in for your nutrition-focused physical exam, you do that head-to-toe assessment. And what you find is that there's mild subcutaneous fat loss, so somewhat hollow orbital fat pads with slight dark circles. The fat in the upper arm is not ample, but it's not quite depleted. And the ribs are visible with mild depressions. You look at muscle areas and there's no loss. 1+ pitting edema was reported and the hand grip strength was unchanged during your assessment today. So which etiology do you suspect? I hope I gave you enough time that maybe some of you are saying acute disease, right? This is a patient who's in the ICU, and it seems like that change has been pretty recent. So I'd agree with you if you said acute disease or injury-related malnutrition. Now, looking at the table of clinical characteristics from Aspen and the Academy, we're going to be over here in this context of acute illness or injury. So the first 2 sets of columns. And what I want you to think about is, would you diagnose this patient with non-severe, moderate malnutrition, or severe malnutrition? I hope I gave you enough time there. Maybe if you're thinking non-severe, moderate malnutrition, I would agree with you. This patient did have a pretty severe reduction in their energy intake. They did have some weight loss within that range of 1 to 2% over 1 week. They had mild body fat loss today with no demonstrated muscle loss yet. And they did have mild fluid accumulation. So you do have 4 criteria. You need at least 2 to provide a nutrition diagnosis. And that nutrition diagnosis could sound like non-severe, moderate malnutrition in the context of acute injury or illness, which of course you would add onto your PES statement, the different clinical characteristics that you use to support that nutrition diagnosis. All right, now we've talked about screening, assessment. We got to spend a little bit of time talking about interventions as to what the evidence says might be appropriate for working with these patients once you do diagnose malnutrition. And I love the title of this slide because it seems very obvious, especially for my dietitian friends on the line, that nutrition support is associated with positive patient outcomes, especially for our patients with malnutrition or risk for malnutrition. But even though I say that that's pretty obvious, a lot of the research is actually fairly recent. So this is based on a meta-analysis by Filomena Gomez. It was in 2019, but what you can see is that there were larger studies published more recently when we look at the data available. So 5 of these studies that she included of the 27 were published between 2015 and 2019. You can see 652 participants in the Nourish trial, over 2,000 in the Effort trial. So the evidence is more recent. And what you can see is that when they looked at patients with malnutrition who received individualized nutrition support compared to no support, there were improved outcomes. So that the nutrition support, which could have been working with them to liberalize the diet, snacks between meals, Nourish, for example, used an oral nutrition supplement. Effort also allowed for, of course, if patients needed enteral nutrition, they used that for appropriate patients. Whatever that tailored intervention was, that group that received individualized nutrition support, that group was associated with reductions in mortality, reductions in hospital readmissions from 18% down to 14.7, improvements in energy and protein intake, and improvements in body weight, with no difference in infection, length of stay, and functional outcomes. Now, when we look at this care continuum, of course, we've talked about this today, but this starts at admission with that screening. Assessment is, of course, extremely important, and intervention, and then pulling that through to discharge. And so there have been QIP projects, quality improvement projects in this area. I'm going to highlight just one, but there are other wonderful resources. If we look at MQII, the Malnutrition Quality Improvement Initiative website, they highlight many patient populations, or excuse me, many QIP projects in their nutrition collaboration that have basically looked at their processes and said, hey, we could improve. One example here is this Advocate Healthcare QIP study. And what they did is they looked at their 4 hospitals and what they were currently doing. At baseline, during their QIP, at baseline, all 4 hospitals were basically using a screening tool, but it wasn't validated. They were doing an intervention, but it was not early. And they did not provide any formal nutrition discharge education or follow-up phone calls to these patients. So they said, let's work on this. Let's do a basic program where 2 of our hospitals are going to start screening with the MST. They are then provided oral nutrition supplements as their intervention within 24 to 48 hours. They did not change education at discharge or post-discharge follow-up calls. 2 other hospitals in that system were put into a QIP enhanced program. So they screened using the MST, but they actually used the screening tool to guide that early intervention. So if a patient had an MST of greater than 2 or equal to 2, the nurse automatically ordered an oral nutrition supplement. So that meant it got there faster, within 24 hours rather than 24 to 48. They did provide formalized nutrition discharge education with coupons. And then at discharge, they provided 4 follow-up phone calls asking about adherence to the oral nutrition supplements. At baseline, their readmission rates were 22%. And their length of stay was 7.2 days. In the hospitals that participated in the basic QIP program, quality improvement program, their readmission rates were reduced to 16.4%, and their length of stay was reduced to 5.4 days. In the enhanced program, the readmission rates were reduced to 15.6%, and the length of stay was reduced to 5.3 days. That meant that when they looked at the economic impact, it was estimated that more than $3,800 was saved per patient in this program because of the avoided readmissions and reduced length of stay. Now, this is far from the only QIP, as I mentioned, but it's one that has been used to inform the MQII, the Malnutrition Quality Improvement Initiative Toolkit. And what they recommend in terms of best practices is that we making sure that we're recognizing and assessing for malnutrition, that we rapidly implement nutrition interventions, and we develop a discharge plan so that we're pulling this intervention through, and so the patients understand what we were doing while they're admitted for their malnutrition and how they can continue when they're in their next care setting or potentially discharged into the community. This is, of course, highly relevant, not only because it's Malnutrition Awareness Week, but also because we do see the emergence now. There is a new global malnutrition composite score, which I'm sure you've heard a lot about, that is taking effect in January of 2024. This is an electronic clinical quality measure. So it's looking at what's documented in the electronic medical records, specifically these 4 steps. So there's 4 components that make up one composite score. The first is screening. The first component is screening for malnutrition. The second is conducting a nutrition assessment. The third is diagnosis. And the fourth is a nutrition care plan for that patient. So what this score does is takes an average of how successfully you've stuck to the optimal care of patients with malnutrition. And then that's reported. It's one of the voluntary measures of the IQR program, the Inpatient Quality Reporting Program for CMS. And what you can see when we look at how this kind of process overlaps, one thing to note is that it does take multiple members of the care team. It's not just dietitians doing this, right? Especially, so we look at component measure 1, for example. And this again, this has been updated, this slide. So instead of that component measure 1 of screening being just driven by nurses, it can also be done by a registered dietitian. The assessment is driven by an RD as well as the nutrition care plan. But check out component measure 3. That's diagnosis. And this is where it's really important that we're working with an appropriate physician or clinician that can write medical diagnoses and make sure that they are relaying this message in their electronic medical records so patients are appropriately have the appropriate diagnosis. And you can see here from the MQII figure that this also is pulled into discharge planning. This is a unique opportunity that you have to connect this patient with the right resources in their community, especially when they have concurrent food insecurity, so that they can ideally work to optimize their nutrition status and limit some of those complications we talked about earlier that are seen in patients with malnutrition. All right. With that, some things to consider in closing before we get into Q&A. So please type in your questions in the Q&A if you have any. But what I hope I've communicated with you over the last hour is that your context is very important for patients. So you, of course, probably have patients in your life that you've seen that others may look at and think this person is malnourished, but they might not have malnutrition according to these criteria. So think about that 80 to 90-year-old Energizer bunny who habitually consumes quite a low amount of calories, but they've maintained a stable weight and they're functioning at the same level. That person might not be at risk. Also, patients who have various forms of nerve injury. So we think of patients who have spinal cord injuries. There is a degree of muscle loss that we would expect, especially in that early time after they have had the injury. And so that might be appropriate depending on what other things are going on. Same with stroke, right? If we have with patients with stroke, they may experience atrophy on one side of the body rather than the other for reasons not necessarily directly related to nutrition. And then also there's patients who may not look malnourished that do have malnutrition, right? And so you've probably had this conversation with other healthcare providers that, yeah, a patient with a BMI of 35 can still have unintentional weight loss or inappropriate weight loss, right? Loss of lean body mass specifically. And they can have poor dietary intake, even at higher BMIs. So that context is important. We want to make sure we're watching the whole patient. We're watching for trends over time, and we're frequently reassessing, especially in situations such as the ICU, where things can change rapidly. And then, of course, lots of practice helps. So hopefully today was a good refresher on the NFPE for those of you who have done it, but practicing on patients is the best way, of course, to develop those skills and to understand what's normal for different patient populations. All right. I'm going to hand it back to, we'll open it up here for some Q&A, but before we get there, disregard the first bullet point there. You do not need to sign in because Susan and Amy are going to put together a list of all attendees. But to get your credit, and this is something we'll email out afterward, the steps will be to go to anhi.org. That is our educational platform. You'll log in or register if you've never been there. And then you'll select the education tab, select print certificate, and you'll enter the event ID on the code on the screen. So your unique code for today is 5, A as in alpha, 8, D as in delta, 4. So you can take a screenshot of this if you wish, or we'll send it out afterward, and that site will remain open for 30 days. So please visit roughly before October 20th in order to get your certificate. And if there's any trouble, please feel free to reach out to me and I can help you through that process. So I will leave this up on the screen for a minute here while we open it up to see if there's any questions in the chat box.
Thank you, Dr. Robinson, for that excellent overview of malnutrition, the nutrition-focused physical assessment. There are a couple of questions coming in. The first one is, what areas of the body may be better indicators of nutrition-related losses versus age-associated changes in the elderly?
Great question. Great question. And I'm not sure it's so much an area that may be better than the other, but there's kind of some context questions that I've heard from clinicians that are helpful. So for example, thinking about the timeline of change, right? Because of course, with age, it's estimated that we lose 2 to 3% of our muscle each decade, right? After a certain age. So we are expecting loss of lean mass with aging. But the question is that loss exaggerated? Is it related to a more recent diagnoses, such as a cancer diagnosis, for example, COPD exacerbations? And has it impacted function? So if you have hand grip strength, that's a great thing to consider, but also maybe activities of daily living. So asking that patient, has this been a more recent change for you? And is it related to anything going on nutritionally?
Okay, this next one is very similar. It just says, can you please expand on or provide good resources for the RD to be able to differentiate what may be age-related muscle loss or fat loss? How would that be best taken into consideration with the criteria?
Yeah. And probably similar to the question before, but resources
Right.
is a great call out for resources. And I would say this is something that over my career I wanted to see is more research in this area to kind of definitively call that out. But what I think I've learned in talking to so many clinicians is that it is really based on your clinical judgment and also your experience with those patient populations. So hands-on nutrition-focused physical assessment is wonderful when you think about not only doing it on patients with malnutrition to gather the data, but maybe also extending that practice to well-nourished patients so that you can get used to feeling like, what is normal muscle? Does a normal muscle feel like for an 80-year-old versus a 50 versus a 30-year-old? So building up that toolkit might also be something that's beneficial.
Okay, I don't see any other questions in the Q&A at this time. So thank you again, Dr. Robinson. It was a pleasure having you speak to us again this year at our symposium. Thank you.
Thanks, Susan.
Our second topic this afternoon is diabetes and nutrition management, challenges and opportunities. Our presenter is Dr. Carly Ruch, who serves as a medical science liaison in scientific and medical affairs at Abbott Nutrition, specializing in adult therapeutics. Prior to joining Abbott, she was a course instructor in nutritional sciences at the University of Florida and a neurology dietitian at the UF Health Norman Fixel Institute for Neurological Diseases. Dr. Ruch completed her bachelor's degree in food science and human nutrition at University of Florida, specializing in dietetics. She earned her master's degree in food science and human nutrition and completed her dietetic internship through the MS Dietetic Internship Program at UF. During her dietetic training, she also served as a research coordinator on a variety of study protocols, including topics on GI dysfunction, inflammation, pre- and probiotics, and the gut microbiome. Afterwards, she worked as an inpatient dietitian at Advent Health in Orlando and served as a preceptor for their dietetic internship program. Her clinical experience spans a variety of disease states such as cancer, GI and neurological disorders, malnutrition, and critical care. Following her time working in clinical practice, Dr. Ruch completed her PhD in nutritional sciences at the University of Florida. Her doctoral research investigated the effect of the Mediterranean diet on improving constipation and intestinal inflammation in Parkinson's disease. During her graduate program, she has taught multiple undergrad and graduate courses on nutrition, metabolism, and research methods. Dr. Ruch has several publications in peer-reviewed journals and has been invited to present her research and nutrition-related topics at both state and national conferences. Welcome, Dr. Carly Ruch.
Wonderful. Thank you, Susan, as well as Amy, too, for organizing such a great virtual conference for everyone today. It's a pleasure for me to talk to you guys about this very important topic on diabetes and nutrition management and go over some of those challenges and different opportunities we as dietitians, but also nurses, because I know we have potentially some nurses on the line too that we see in our clinical practice. And I will say I'll try to share some of more insights as well. I was able to attend the ADA conference earlier this year, so lots of exciting new research going on in this area. All right. Oh, pardon me. All right, so for my disclosures, as Katie mentioned in her previous talk, the content of this program is intended to be evidence-based, non-promotional, with no product discussions. The event is supported by the Abbott Nutrition Health Institute, or ANHI, as it's eligible for 1 credit hour of continuing education for both dietitians and nurses. At the end of the program, I will also have a slide with instructions on how to claim your CE through anhi.org with that unique identification code. And if you're not familiar with anhi.org, I really encourage you again to check them out after the program today. They really are an excellent free resource of continuing education programs, as well as other resources like podcasts, infographics, etc., for both dietitians, nurses on a variety of topics, from adult, pediatric nutrition, from a non-branded platform. And then finally, as my last disclosure, as you heard, I am an employee within medical affairs and research at Abbott Nutrition. Now for our learning objectives for today, we're going to identify those diabetes-related nutritional needs, as well as some of those gaps in diabetes care. And we'll also bring in those relevant guidelines for nutrition care of patients with diabetes. And finally, evaluate the evidence to support nutrition therapies and technology, both in the inpatient and the outpatient setting for diabetes management. Now, to set the framework for what we'll discuss today, we'll mostly discuss nutrition management for diabetes as a whole. However, I do recognize that there are differences between types and the management for these conditions. And this is due to their pathophysiology. So for type 1, it's typically characterized as an autoimmune disease. Oh, my clicker is, there we go, is acting a little slow for me today, so I'll just use this. So type 1 is characterized as that autoimmune disease, typically through destruction of those beta cells of the pancreas, resulting in a loss of insulin production. So we have this exaggerated inflammatory response, where typically we see those T cells playing a role in that destruction due to that abnormal activation. And because of this, glucose fails to enter the cells and accumulates in the blood. For type 2, that's going to be characterized as insulin resistance due to beta cell dysregulation. So insulin is being produced, but not binding to those insulin receptors. And what we see here often is a disrupted feedback loop between tissues and beta cells. Over time, that dysregulation can lead to loss in beta cell function. And we also see some differences in the pathogenesis of type 2 diabetes as related to someone's genetics and even other environmental factors that may be at play. And as you heard from my background, I have a very big passion and fascination for the microbiome, and we have seen some studies showing how the microbiome can play a role in the development of type 2 diabetes as well. And when we look at how prevalent the condition is here in the US, you can see about 11.3% of Americans have diabetes. However, of that 11%, it's estimated about 23% are actually undiagnosed. And as you would expect here in the US, the large majority of people with diabetes have type 2. And when we think about that economic impact of managing diabetes, it's quite taxing on our healthcare system and workforce. We know obesity is certainly closely linked with diabetes as well. This number, 37%, is actually showing prevalence of diabetes in people with class 3 obesity, so a BMI greater than or equal to 40, comparing those to BMIs within the normal weight range. We know diabetes typically coexists among other conditions like obesity, and those living with it are at increased risk of complications. So the first being hospitalizations. We also see increased risk of retinopathy. It's the leading cause of new cases of blindness in adults from damage of those blood vessels of the light-sensitive tissue at the back of the eye or the retina. With nephropathy, almost 40% of people with diabetes also have chronic kidney disease as well. Cardiovascular disease is also closely linked with diabetes because high blood sugar can damage those blood vessels and nerves, and it's the leading cause of hospitalizations in this patient population. And then finally, we also will see some nerve damage too that's common, leading to neuropathy, resulting in numbness and pain. And when we look at what factors are associated with a greater risk of diabetes-related complications, this is probably not new for particularly my dietitians in the room: overweight, obesity, physical inactivity, high cholesterol, smoking status, elevated A1C, high blood pressure, right? Now I'll pause here and I just want you to think to yourself about, what do all of these factors have in common? So if you thought lifestyle factors, you are absolutely correct. So these are all modifiable factors, modifiable through lifestyle. So of course, when we look at what factors are associated with prevention of these complications, CDC data tells us that having an HCP that can provide diabetes care, whether that's a physician, a dietitian, a nurse, etc., being physically active, maintaining a healthy weight, whichever at what status that is meaningful to you, statin treatment. And we also see meeting these ABC criteria. So A meaning A1C less than 7%, B meaning blood pressure within normal ranges, and C being cholesterol, having normal cholesterol, non-HDL cholesterol ranges, and even non-smoking status too. And we see this come up in this criteria for dyslipidemia because people with diabetes are more at risk for dyslipidemia, and they may need statin therapy to prevent diabetes-related complications. When we look at the data on whether people with diabetes are actually meeting these ABC goals, it's estimated that less than 1 in 4 adults met the combined target goals. So in this study, diabetes care was associated with lower LDL cholesterol levels and better achievement of target goals than those without care. This study also highlighted some differences in certain populations for achieving care targets, such as ethnicity and even insurance coverage too. Looking at those different care pathways for people with diabetes, we have lifestyle management that includes that diabetes, self-management, education and support, or DSMES, which I'll talk about a little bit later, and medical nutrition therapy, MNT, of course, and even assessment of psychosocial, emotional health concerns too, because we know that that can also impact self-monitoring and management strategies in this patient population. Of course, we're going to depending on the patient and their goals, we may need to recommend pharmacologic therapy that's going to be targeting hepatic glucose output, as well as therapies that may influence cardiovascular risk factors and even renal risk too. And some of the newer evidence that we're starting to see, particularly at ADA this year and even in the literature, is a growing use of glucose monitoring and even insulin delivery devices and how we can use these technologies to improve management and care of people with diabetes. And then finally, of course, incorporation of that diabetes education and medical specialist, whether that's the dietitian, nurse, etc., is also going to be important for management in people with diabetes. And I know we can all appreciate in the room the important role that nutrition plays in the management of diabetes. A recent consensus report on nutrition therapy for diabetes and pre-diabetes was published in 2019 and really highlighted the role of the dietitian and how medical nutrition therapy can improve outcomes, including promoting and supporting healthful eating patterns, improving those cardiovascular and laboratory values like A1C, blood pressure, cholesterol, achieving and maintaining body weight, delaying and preventing complications, as well as providing people with diabetes and individuals those practical tools for day-to-day meal planning, because oftentimes that's kind of where some of this education falls short. And we'll talk a little bit more on these guidelines a little bit later too. So to pause there, we kind of set the scene for diabetes overall and briefly touched on the impact of nutrition. So let's next discuss the mechanism of hormones, incretins, and the role specific nutrients and food components play in this process. So we talked briefly on the role of insulin in diabetes, but there are a number of other hormones that regulate blood sugar, appetite, and satiety known as incretins. Glucagon is an insulin counter-regulatory hormone produced by the alpha cells of the pancreas and is released during fasting to stimulate gluconeogenesis and breakdown of glycogen reserves via glycogenolysis in the liver. Therefore, glucagon excess due to insulin deficiency can lead to hyperglycemia. Glucagon and its receptors are also known to suppress appetite, enhance energy expenditure, and lipid oxidation, which is why you also may hear about it more recently with weight loss drugs like retatrutide, for example, those triple agonist drugs now. So there's a really complex balance between too much and too little glucagon. Now, I know you all have heard about GLP-1 very recently in the news, and more evidence is coming out in the literature. So glucagon, like peptide 1 or GLP-1, and even glucose-dependent insulinotropic polypeptide or GIP, are newer weight loss and diabetes therapeutics. So you might have heard of Ozempic, Wegovy, Mounjaro, etc., right? So GLP-1, we'll talk about more on the next slide, but it's been shown to stimulate glucose uptake in that adipose tissue. It's also been shown to impact postprandial and fasting glucose and A1C. GIP as well can also help with stimulating glucagon secretion from those alpha cells in the pancreas. And its effect may be muted relative to GLP-1 in people with type 2 diabetes. And you'll also see some evidence out there that the combination of GIP with GLP-1 may help with regulating some of those side effects that we might see with GLP-1 alone. But let's talk a little bit more about GLP, which is an incretin secreted by the enteroendocrine cells, or L cells, of the GI tract. I mentioned GLP-1 can regulate glucagon and insulin secretion, which in turn decreases glucose production. GLP-1 can also reduce gastric emptying, which in turn can lead to that appetite suppression. GLP-1 has also been shown to improve insulin sensitivity in the skeletal muscle and improving glucose utilization and transport. So this was a hot topic of conversation this year at the ADA, as I mentioned, given all the new research on GLP-1 receptor agonists on weight loss and glycemic control. However, we do know that there are specific nutrients and food components that can influence GLP-1 secretion, such as fiber, short-chain fatty acids, monounsaturated fats, proteins, and amino acids. So let's dive a little deeper on this more in the next slides, including how these nutrients influence the treatment of diabetes. So first we'll talk about my favorite food component, which is dietary fiber. So this is the indigestible portion of carbohydrates. There are many different types of fibers and each function differently. There's evidence from a large cohort study that higher intake of insoluble fibers, specifically from cereals and whole grains, are associated with reduced insulin resistance and risk of developing type 2 diabetes. Dietary fibers such as viscous gel-forming fibers can also influence GI transit time and in turn improve postprandial glucose response. And then we also have fermentable dietary fibers that can promote production of short-chain fatty acids, which in turn can modulate GLP-1 expression as well as GI and immune function. So here is a list of examples of different fiber types that's just meant to serve as a resource for you here. I know in school, and when I was in school, we only really talked about soluble and insoluble fibers. But what's great about this slide is that we also differentiate the differences between not only soluble and insoluble, but also fermentable and non-fermentable fibers too. And specifically, when we look at those fermentable soluble fibers, there are some that meet classification for prebiotic, which is defined as a substrate that is selectively utilized by host microorganisms to confer a health benefit. Examples of prebiotics include short-chain fructooligosaccharides, inulin, GOS, and even HMOs too, or human milk oligosaccharides. These prebiotics can be further broken down by the gut microbiota and stimulate growth of commensal microbes such as bifidobacterium and lactobacillus. Fermentation of prebiotics leads to an increase in those short-chain fatty acids like acetate, propionate, and butyrate, which can then be used for cross-feeding for other beneficial bacteria and also help with reducing that luminal pH and inhibit pathogen growth and facilitate reabsorption of water to reduce diarrhea incidence. Butyrate specifically is the preferred energy source for those colonocytes and important for maintenance of the GI barrier and immune function. And if you want to ask me more questions about short chain fatty acids and butyrate, I welcome that at the end of this Q&A too, just because I love talking about it so much. Okay, so this slide summarizes some of those points on short chain fatty acids I mentioned on the last slide, but specifically when we think about their role in diabetes, areas of future investigation really center around how dietary interventions focus on increasing production of short chain fatty acids that can improve inflammation, intestinal permeability, and even the gut-brain axis like satiety in people with diabetes. We also have dietary fats, specifically those monounsaturated fatty acids and polyunsaturated fatty acids, or how we like to shorten them as MUFAs and PUFAs. They may also influence beta cell proliferation and GLP-1 secretion by the L cells of the GI tract. Supplementation of omega-3s, which are a type of polyunsaturated fat, have been shown in recent meta-analysis to be associated with reduced fasting blood glucose and markers of insulin resistance. Protein is another macronutrient important for the treatment of diabetes. Another recent meta-analysis published by you and colleagues, which I have as that first reference point listed at the bottom, combines results of 13 randomized controlled trials to investigate the effect of a high protein diet on glycemic control in people with type 2 diabetes. They found that high protein diets had no difference on fasting blood glucose or A1C specifically, but did show an association for lower LDL, triglycerides, total cholesterol, and HOMO-IR, which is a marker of insulin resistance. We know that further studies are definitely needed, as there were several limitations of the study. We also know that protein is satiating and can also slow gastric emptying, as well as stimulating GLP-1 and insulin secretion. Timing of protein or lipids may also have varying effects in respect to glucose tolerance, in which we see studies showing that preloads of protein as that macronutrient before carbohydrates are associated with improved glucose tolerance. And then finally, just to wrap this section up, there's also some investigation and work on dietary factors like bioactive compounds that may influence the progression and treatment of diabetes. So this review that I have cited down below here highlights the action of bioactive compounds like phytochemicals and peptides with influencing mechanisms involved in glucose metabolism. So we have some phytochemicals in certain plant species like flavonoids, terpenoids that may influence microbiota or influence glucose transporters like stimulating GLUT4 translocation and increasing glucose uptake as well. And then there's also other bioactive peptides that may play a role in incretin metabolism and inhibiting enzymes involved in digestion of carbohydrates. All right, so moving on, in this section, what I would like to discuss next are some of those specific guidelines and consensus statements that discuss proper nutrition for people with diabetes. And I know I don't, again, have to highlight too much for everyone in the room or in our virtual room here about the crucial impact of MNT in people with diabetes. However, looking at the data, you can see that MNT has been shown to provide reductions in A1C that are similar or greater than what's expected from treatment of available medication for type 2 diabetes. MNT is also associated with up to 2% decreases in A1C in both type 2 and almost type 1 diabetes in about 3 to 6 month period. Diet may also play a role in reducing production of advanced glycation end products or AGEs, as well as reducing inflammatory markers and oxidative stress markers in people with type 2. And again, I know you probably all have seen this probably in practice yourselves, how weight loss can also lead to an improvement in insulin sensitivity. And we'll talk a little bit more on recommendations for weight loss a little later. So behavior change specifically for diet can be really challenging in people with diabetes. And honestly, it can be really challenging in people without diabetes, right? Behavior change is just really difficult for a lot of people, even including myself too. And you've probably heard of that acronym DSMES, or Diabetes Self-Management Education and Support, which is an evidence-based, cost-effective tool to empower people with diabetes to navigate self-management decisions and activities. This is done through an ongoing process of facilitating the knowledge, skills, and ability necessary for diabetes self-management, as well as activities to assist a person in implementing and sustaining the behaviors that are needed. The American Diabetes Association does publish their standards of care yearly and has specific callouts for incorporation of the DSMES into the diabetes care plan. And I will say, with some of these recommendation numbers, I haven't been able to update my slide just yet because we do have an updated reference for the 2023, so that those recommendation numbers may differ just slightly. But you can see in the 2022 recommendation 5.1, it says that all people with diabetes should participate in self-management education and receive the support that they need to master those skills necessary for diabetes care. They even also go on to recommend, in recommendation 5.5, some of those barriers to diabetes self-management education and support access may be mitigated even through telemedicine approaches. So this is something great to think about, particularly when we don't have enough access or resources to enough dietitians, or maybe even out to rural areas or remote areas. Like I live in a rural area myself. However, I do recognize that depending on the patient population, telemedicine and digital technologies might be more of a challenge and a learning curve right now. But it's great to see a call out here that telemedicine should be thought about and even incorporated as needed. In 2020, there was also a consensus report that was published in collaboration with the ADA, as well as the Association of Diabetes Care and Education Specialists, the Academy of Nutrition and Dietetics, as well as other professional organizations, to outline the benefits of DSMES, including critical times to provide it, and discuss those potential solutions to access and utilization barriers. So characteristics of the DSMES include some formal series of didactic classes or education classes, technology-based services as applicable, and of course, family and peer support too. And when we look at the recommendations for MNT, we can see that the aim is to reduce A1C by about 0.5 to 2%. And to do this, they recommend about 3 to 6 encounters during that first 6 months of diagnosis, so that really critical time point when they're being onboarded with this new information. And then, of course, we want to follow up based on those patient individual needs. And focus areas that we should think about reflect on topics, whether that's purchasing food, preparing meals. Again, you want to also think about those social determinants of health, like food access, etc. And when we look at what that consensus recommendation says, it mentions that those providers should ensure coordination of medical nutrition therapy plan with that overall management strategy that in both incorporates that DSMES, but also medications, physical activity on an ongoing basis. So a really multidisciplinary collaboration for the care of someone with diabetes. What's really nice in that consensus report paper is that they highlight nicely these 4 critical times for DSMES education, which include at diagnosis, like I mentioned, annually, or when not meeting treatment targets. And the next time would be when complicating factors develop. So think hospital admissions, new wounds, for example. When transitions in life and care can occur is that final piece too. So you can see in the core of the figure here, DSMES should incorporate medication adherence, proper nutrition, physical activity, and even healthy coping strategies. Monitoring should be included throughout the continuum of diabetes care with the aim of problem solving and risk reduction of diabetes-related complications. I mentioned weight loss in those with larger BMIs is recommended specifically in type 2 diabetes, as it's been associated with improved metabolic markers and insulin resistance. So you can see that 2019 consensus report from the ADA on nutrition therapy for adults with diabetes and prediabetes recommends that in prediabetes, A weight loss goal of 7 to 10% for all individuals should be aimed for preventing progression to type 2. And this data comes out of that diabetes prevention program trial. In type 2 diabetes, 5% weight loss is recommended to achieve meaningful clinical benefit, but the goal for optimal outcomes may be up to about 15% or more when needed and can be feasibly and safely accomplished. As well as we also see recommendations that for all patients that have overweight or obesity, lifestyle modifications to achieve and maintain a weight loss of at least 5% is recommended for all patients with diabetes and prediabetes. And when we think about, how this applies in clinical practice, I really like to put this type of number when I was practicing myself with patients, for example, because it really goes to show that to get those clinically meaningful benefits, patients don't need to have very dramatic weight loss, right? They can maintain a weight loss of 5% to still see some benefit in the management of their diabetes care. And we see that what we like to see too is that in that consensus statement from the 2019 guidelines, they do highlight that the evidence does not identify one specific eating plan that is clearly superior to the other, because oftentimes that's definitely questions that we get asked as dietitians, nurses, what's the best diet for me? So now we have some statements here from the ADA saying that there's not one particular plan that's superior to others, and that individualized eating plans should support calorie reduction, however that's meaningful to your patients, right? So that could be portion control, meal replacements, or other behavioral interventions in the context of a larger lifestyle program. We do also see some tactical recommendations in the ADA standards of care. So in recommendation 8.11 in those 2022 standard of care guidelines, you can see that they do recommend that short-term dietary interventions using structured, very low-calorie diets of 800 to 1,000 calories per day may be prescribed carefully for selected patients by trained practitioners in medical settings with close monitoring. And you see, I slowed down the cadence of my voice to really emphasize the importance of trained practitioners and close monitoring in this specific type of approach. You'll see that there's no specific protein recommendations here, but like we see with other guidelines, I do want to highlight that the utilization of high protein diets during the short-term, very low-calorie diet phase is really crucial for preserving lean body mass. At the ADA, I did also get the chance to meet Dr. Osama Hamdi from Harvard, who leads the Joslin Diabetes Center in Boston. He's actually done a lot of work in this area of very low-calorie diets for people with diabetes, and even presented new research that demonstrated that lean body mass can be preserved when pairing high protein with a very low calorie diet using a structured lifestyle intervention with people with type 2 diabetes. So again, just to reemphasize, we don't necessarily want to just blanket prescribe a very low calorie diet in these people and move on, right? We really want to make sure that they are meeting enough protein to preserve that lean muscle mass. He does even have some long-term follow-up data that participants showing they can maintain a 10% weight loss after 15 years. And I'll show some of his research data in some later slides, but I'm happy to connect with anyone who would like to see more of his team's work if you're interested too. And then finally, with 1611, you'll also see a call out for the need for structured and specific discharge planning for our hospitalized patients. So really emphasizing the importance of those transitions of care from inpatient to outpatient too. We do hear a lot lately about personalized nutrition with diabetes, and we want to take the same approach that is dependent on patient needs, goals, and even food preferences too. So again, just to emphasize again, there is no ideal macronutrient ranges for people with diabetes. Plans should be customized, whether that's low-calorie meal plans with meal replacement to induce weight loss, utilizing healthy eating patterns like a Mediterranean diet or other types of meal plans, such as low carbohydrate with additional support too. And again, just to really emphasize what the research has said in this area, when you think about that diabetes prevention program, so oftentimes when we think about diet in someone with diabetes, we often think of low carb diets. But that diabetes prevention program actually was not a low-carb diet. It was a low-fat diet, okay? So really highlighting that there's no ideal macronutrient range, and it really can be customized depending on your patient's preferences and needs. So let's take a look further into those MNT guidelines for specifically the hospital setting and special populations too. So in the ADA standards of care, I'll highlight that even in the hospital setting, they point out that there's no single meal plan or specific distribution of macronutrients that is ideal. But they do recognize, specifically in hospitals, that may still choose a consistent carbohydrate meal plan to easily facilitate insulin dosing for patients and nursing staff too. Target blood glucose range in hospitalized patients is pretty consistent between the American Society for Parenteral Nutrition, Society for Critical Care Medicine, and even the ADA, somewhere between 140 and 180 milligrams per deciliter. We see that the ADA does recommend insulin therapy if patients experience a blood glucose greater than or equal to 180 on 2 occasions or more. Once they are on insulin, we should be monitoring blood glucose every 30 minutes to 2 hours in patients, just depending on the specific patient care plan. The CGMs may also be incorporated here, continuous glucose monitors, to better detect hypoglycemic events. But I will highlight that this is definitely going to be up to hospital policies on their use. We really haven't seen any consistent recommendations yet in this area from the ADA, and that's consistent even with those new 2023 standards of care. But again, in ADA, they do also call out that stringent blood glucose goals should be reserved for those select patients without significant hypoglycemia or risk for hypoglycemia. Older adults may also have some special considerations for blood glucose management. So for example, risk of cognitive impairment as well. You might want to consider the context of that, dementia, Alzheimer's as well, polypharmacy too, so they might be on multiple different types of medications, frailty, etc. So therefore, the ADA does recommend that older adults should be screened and monitored for self-management capabilities, since it can be difficult to adhere to self-care activities like glucose monitoring, insulin dosing, even sometimes preparing meals too can be really difficult with some of our older adult populations. Here are some considerations from the standards of care to think about for mitigating hypoglycemic risk in older adults, like risk such as risk screening, consideration of CGMs, and appropriateness of stringent glycemic controls. Helpful tips for ascertaining hypoglycemic risk with patients and family could be asking about skipping meals, for example, meal timing, or inadvertently repeating doses of medications too. And so I like to highlight the skipping meals and meal timing, because oftentimes that can sometimes be on us as the clinician to ask a little bit more questions with curiosity, right? So instead of just asking the patient, how are you eating? Well, I'm eating fine, right? Maybe asking more of, walk me through a normal day at home. You know, what time do you typically eat breakfast, or what time is the first meal of the day, if you don't want to assign some of those categories, because some people might just say, I don't eat breakfast, right? So those are just some considerations, particularly when working with this older adult population. For older adults who also want to be, we also want to be cognizant of loss of lean body mass over time. So I know Katie earlier in her presentation talked about how just naturally over time we might lose between 2 to 3% of muscle mass as we get older. But we really want to keep in context of the older adult and making sure that that loss of lean body mass is appropriate for their age. And it's not only because of age-related wasting that we see loss of lean body mass, but also diabetes itself. So here I'm showing you some DEXA scan data that was published by Lee et al. So that reference down at the bottom, comparing older adults with or without diabetes over a 4-year period. So we have change in appendicular lean mass on the y-axis, and you can see when they stratified this by sex, men and women with diabetes lose more lean mass over time than those without. Over time, without appropriate interventions, this may increase their risk for sarcopenia, as well as decrease functional status too. Tighter glycemic control does not appear to offer any benefit for at this time, particularly for our perioperative or surgical populations. However, we do want to perioperatively screen for automatic neuropathy, renal failure, ischemic heart disease risk, as well as cardiac autonomic neuropathy has been associated with higher risk of complications following surgery. Autonomic neuropathy may also impact gastric emptying and increase aspiration risk as well. When it comes to our perioperative patients, we also will want to consider withholding metformin on the day of surgery due to small risk for developing lactic acidosis postoperatively. For our patients with diabetes requiring nutrition support, diabetes-specific formulas have been associated with positive outcomes, such as reduced glycemic variability, insulin requirements, total ICU costs, and mortality when compared to a non-diabetes-specific formula. And we'll chat a little bit more on diabetes-specific formula in some of the later slides, particularly as it relates to oral nutrition supplements. But what I will highlight is that the European Society for Clinical Nutrition and Metabolism, or ESPN, also has a call out in their guidelines for the use of diabetes-specific formula in people with obesity and diabetes who are on nutrition support. And this is due to the composition of diabetes-specific formulas. And again, we'll talk a little bit more on the composition a little bit later. And before talking about oral nutrition supplements, I've already kind of mentioned briefly about continuous glucose monitors and CGMs. So I want to highlight some of those newer parameters beyond, I want to highlight it as a newer parameter beyond blood glucose and A1C when working with people with diabetes. So when it comes to assessment of glycemic control, A1C and blood glucose monitoring, I know most people are familiar with. However, in this new age of CGMs becoming more popular, and we also have some new parameters that we can monitor in these patients. So time and range, or TIR, is a newer outcome measure that looks at percent of total time and range of 70 to 180 milligrams per deciliter, as it's been associated with decreased risk of microvascular complications and is recommended by the ADA as a useful parameter for glycemic control. So I want you to think to yourself, have you worked with any patients with a CGM before? Maybe you haven't. I know this is definitely becoming more popular over the last couple of years. And maybe we might also start to see some trends with more and more patients coming to us with these CGMs. So in case you do happen to see someone that does have a CGM, I want to show you an example of an assessment of time and range using that CGM. So you can see the CGM will provide data on percent of the time that they were either hyper or hyperglycemic, which can be helpful. And it's recommended that when you are reviewing these CGM reports that you review it in a 2-week period just to get enough data points. So you can see for non-pregnant adults, time and range goal is going to be greater than 70%. And for older adults, this may be even a little bit more liberal, above 50% as appropriate. But what's important to highlight is that each 5% improvement in time and range is considered clinically significant. So what that 5% improvement results in is an additional 75 minutes that they are in range. Okay, so that's one of the main takeaways with these CGMs that I want you to remember is how can you work with your patients to find an additional 75 minutes to get them in range. Okay. And this is a really great opportunity for both the dietitian and nurse when you're looking at these CGMs to really pick out what times of day are your patients having a little bit more trouble and making those individualized recommendations based on these reports. And if you're interested in learning more about reading CGMs and how to incorporate it into practice, I really am going to encourage you to visit anhi.org afterwards, because they do have a wonderful continuing education programs that actually dive into this a little bit more and provide more information in this area. So the next special population I do want to talk about is managing wounds in patients with diabetes, because we know that delayed healing is also common in this population. So oftentimes, particularly in the hospital, we might see, unfortunately, pressure injuries. So that's going to be that localized damage to the skin or underlying tissue as a result of pressure or pressure in combination with shear. Pressure injuries usually will develop over that bony prominence, but they could be also related to a medical device or object too. And we see that pressure injuries are very frequent and common occurring health problem across the world, and they can definitely be very painful and costly and a burden to our healthcare system. And when we think about the types of people that are at risk of pressure injuries, of course, those with limited mobility, larger BMIs, or even very low BMIs too, moisture, older age, right? But we can see diabetes in particular is highlighted here as hyperglycemia leads to osmotic diuresis and dehydration, which can result in decreased tissue perfusion and oxygenation, okay? So these lists of risk factors come from the international guidelines, including the National Pressure Injury Advisory Panel, or NPIAP. The 2019 international guidelines highlight the importance of monitoring nutrition status and even glycemic control when assessing for risk of pressure injuries and providing a specific framework for the treatment of pressure injuries that you can check out too. Moving on from pressure injuries, we often think about, well, what about diabetic foot ulcers or DFUs? So diabetic foot ulcers can develop after abnormal pressure is applied to the foot and not felt due to that sensory neuropathy. And this over time leads to superficial callus formation. And then we have inflammation, even minor trauma that can also impact stress and induce hemorrhage beneath that callus. On removal, the callus presents with that full thickness ulcer, and more severe DFUs can actually extend deeper into the muscle and bone. So as you can imagine, these DFUs can really impair physical functioning, quality of life, and increase healthcare utilization. And you'll see prevalence is quite high here in the US at 13%, where globally it's actually lower at about 6.3%. Risk factors that increase risk of developing a DFUs include, no surprise, malnutrition risk, peripheral vascular disease, history of neuropathy, poor glycemic control, right, etc. too. And we look at what the evidence has to say on nutrition in this area. A lot of the evidence has been generated by Dr. David Armstrong and his group at USC. Dr. Armstrong and colleagues went on to create this expert consensus and guidance document in collaboration with the American Limb Preservation Society. So these were just recently published last year in 2022, and they're actually a really great pocket guide, and I have a link for it in my handouts here, so you can check that out a little bit later today. But specifically with nutrition, they discuss those protein recommendations, and as you can see, the list is going to vary whether or not patients have malnutrition, obesity, stress, and illness. For those that work in the critical care setting, a lot of these recommendations may look familiar as they are closely aligned to what we see with those 2016 Aspen SCCM critical care nutrition support guidelines. They do go on to discuss other dietary recommendations, calling out recommendations for arginine, glutamine, even HMB at those appropriate dosages. Vitamin C, zinc, E, D, as well as those MUFAs and PUFAs may also play a role in management of DFUs. So again, really great reference to check out later today if you haven't reviewed these already. So guiding us back into those nutritional interventions, let's move on to discuss the evidence on diabetes-specific formulas, particularly as it relates to oral nutrition supplements. So I have this table here that lists the differences between a standard versus a diabetes-specific formula. Most of you are probably already familiar with these differences, but I'll point out a couple of things such as, for those that aren't, such as modified carbohydrates and fiber that are low glycemic index and meant to delay emptying of the stomach and reducing glucose, improving glucose control, as well as a higher content of MUFAs and even PUFAs too. Calling back to some of those hormones and incretins that we discussed earlier, we do have some studies that have investigated the effect of diabetes-specific oral nutrition supplements on these hormones when compared to oatmeal. They found that significant increases in postprandial GLP-1, glucagon, and PYY, which is another appetite regulating hormone, suggesting a role for diabetes-specific oral nutrition supplements on modulating satiety that are high in specific nutrients like MUFAs and proteins. And I'll share, one of our nutrition scientists even presented data at the ADA conference this year that also was supportive of these studies that I'm showing you now too. We talked a little earlier about the roles of MUFAs on glycemic control before, and this meta-analysis shows that when combining results of 18 different studies looking at both oral and enteral diabetes-specific formulas compared to a non-diabetes-specific formula, as expected, there were observed improvements in glycemic control. And I will note that these are not absolute values that I have listed here on this slide, but rather standardized mean differences. And as you can see, diabetes-specific formulas are associated with reduced glucose response, variability, A1C, and even lower insulin dosing, triglycerides, and higher HDL concentrations. For the purposes of time, I'm not going to go over each of the different studies that I have listed on table, but I really wanted to provide you with some of the evidence on the use of diabetes-specific formulas in different patient populations, including outpatient weight loss. We also even other different types of settings like community and long-term care settings too. So really great resource to review some of the literature a little bit later as well. But one of the studies I do want to highlight is one of the recent randomized control trials that Dr. Hamdi, who I mentioned earlier, was a collaborator on. So the aim of this pilot study was to assess the efficacy of diabetes-specific formulas on glycemic response when used as a meal replacement 2 times a day. So the first phase was to collect baseline data using a blinded CGM for 1 week, followed by an intervention phase for another week. During baseline, participants were asked to maintain their usual diabetes management behaviors like medication, exercise, and typical diet with 3 main meals and 2 daily snacks. The control group, or group 1 that I have listed on the table here, continued this during the intervention phase, and group 2 and 3 continued these behaviors, but instead also replaced a diabetes-specific formula for a meal 2 times. Both groups at breakfast, and group 2 as an afternoon snack, whereas group 3 was a pre-bedtime snack. So just trying to differentiate if there's any differences in timing during the day. So the rationale for replacing for breakfast is that blood sugar is typically higher in the morning, and the aim was to see if replacing at other times could also impact those other outcomes too. And when they looked at postprandial area under the curve 2 hours after breakfast, they found that all groups experienced lower blood glucose levels when compared to their baseline values. And this is expected because the control group was what is considered a standard of care intervention. However, when we compare the intervention groups to the control, you can see postprandial blood glucose was significantly reduced in the group receiving diabetes-specific formula at breakfast and an afternoon snack compared to controls. There was a trend observed for group 3 who replaced a diabetes-specific formula as a bedtime snack, but this was not significant. When we do quantify this, we see that approximately 50 to 52% relative decrease after breakfast when diabetes-specific formula is replaced 2 times a day, compared to only 27% in the control group. And I will highlight that this was a pilot study, so it wasn't powered large enough to observe differences in outcomes like glycemic variability or percent time in range. But nevertheless, it does demonstrate how diabetes-specific formulas can be particularly helpful when working with patients to reduce postprandial blood glucose, and future research should really look at percent time in range and glycemic variability in larger trials. And for the last part of my talk today, I want to discuss the impact of nutrition interventions and self-monitoring, again, for people with diabetes. Particularly taking a look at some of those digital technologies that we now have access to. So you can see digital technologies could involve things like nutrition, physical activity apps, web portals or text messages to promote adherence. I know a dietitian that works in private practice. She has a daily texting program where she has a very small number of people that she checks in with daily just to provide that dietitian in a pocket. So that could be one way to deliver diabetes care. Insulin delivery apps, as well as other blood glucose monitoring apps. Aid systems or automated insulin delivery devices are also a newer area of technology, as well as insulin titration apps too. So you can see there was a recent consensus support from the European Association for the Study of Diabetes, as well as the ADA, that highlight recommendations relating to digital health. And they noted that all healthcare providers should be knowledgeable of digital health technology and their strengths and weaknesses, right? Because we know that some are better than others, and we also have some compliance and ethical things to consider too. But these digital technologies can support and inform people with diabetes on the use of digital health apps to augment management. And we can even use some of this health data to improve quality of care and even health outcomes, which I'll show you on the next slide here. So we hear a lot more, particularly in the research world, and even outside of it too, about AI, machine learning, precision nutrition, right? So hot topic words that I'm throwing out there. So this was a retrospective pilot study of 64 participants with type 2 diabetes at the Twin Precision Nutrition Program. Participants wore CGMs, used smartwatches like a Fitbit, Bluetooth-enabled blood pressure cuffs, and scales to track as biometric feedback to the program's app. And they also recorded food intake in the app too. What was really interesting about this study is that they used machine learning algorithms to analyze the composition to determine what drives specific glucose responses for each participant using data from their CGMs, their smartwatches, and scales. The program also provided nutrition counseling based on the information that was collected and recommended specific foods to reduce blood glucose spikes. So what they found after 90 days was reduction in A1C parameters, as well as a change in the percent of patients with an A1C less than 6.5%. They also found a reduction in body weight, and as well as significant changes to fasting blood glucose, HOMA-IR, and as well as mean glucose from CGM, C-peptide, et cetera, too. So 10 years ago, I know precision nutrition really seemed like more of a dream for a lot of us, but now we actually have more practical research showing how we can use tools for many of our patients to improve quality of care that they receive. And I'm really excited to see what the next 10 years of innovation will actually bring us to. So this is not to say that dietitians and nurses are going to be out of jobs, replaced by robots, right? But rather, we can utilize these technologies and incorporate them as part of our nutrition care process to support MNT. On the inpatient side, which I know probably a lot of you are practicing in, self-monitoring and digital health may be less utilized given the patient condition, right, and priorities of care. But something to think about is when you are called on or consulted to provide that diabetes education, how can you be that facilitator of change when you get that new consult? Maybe you're providing your patient or the caregiver a resource list of available digital technologies that they could consider. Or maybe it's at discharge, you're working with case management to ensure that they have the appropriate follow-up appointment with the outpatient dietitians for classes where they can then work more one-on-one with the patient caregiver to create that individualized care plan. So ultimately improving those transitions of care and patient outcomes as well here too. So to conclude, we talked in depth about how diabetes is a complex condition associated with a wide variety of complications, and that management strategies exist to support self-management. Those guideline recommendations highlight the importance of these nutrition strategies to mitigate factors affecting diabetes, and the use of technology may be a plausible method for integrating diabetes care and assessing glucose management too. And with that, concludes my program for today. Again, ignore that first point there about adding your names and credentials to the chat box because we will get the attendance after today's program. But to show you how you can claim credit for today's program, starting tomorrow, you can go on to anhi.org where you can log in, register, and enter in this unique identification code. And that is AAE35. Again, that code is going to be AAE35. And I do believe Susan and Amy also have access to those instructions as well if you need them afterwards to claim your CE. And with that, I will, I'm happy to take any questions that you all have. Thank you.
Thank you, Carly, for that great overview of diabetes and the challenges we face. I know we have many challenges with our inpatient population, but at our hospital in Toledo, we do a quick education and then refer them to our outpatient diabetes center. And that works very well. I have a question here from Katie Van Buren. It says, are there any evidence-based recommendations on provision of HS snacks for acute care hospital stays and at home? If no evidence-based guidelines, what is the best practice? Our hospital is struggling with overnight hypoglycemia for inpatients.
Gotcha. So recommendations for high carbohydrate snacks, is that what I'm understanding?
No, I think just in general, she's asking, Katie is actually from one of our ProMedica sites. She's asking about provision of bedtime snacks for patients with diabetes. We did away with that unless they were on a really high calorie kind of, diet that we needed to meet their caloric needs.
I can't, off the top of my head right now, I can't think of specific guidelines or resource available, but I imagine that there might be some from the Academy of Nutrition and Dietetics. So I'm definitely happy to follow up on that and see if there's any good resources or information in that topic area after today that I can send to you all.
Okay, thank you. And this next question is from Summer. It says, can you share additional resources for the app options mentioned for monitoring blood glucose or where they may compare the app options?
Yes, I will. I believe there has been some papers published that have talked about this a little bit further, so I can definitely share that after today too.
Okay, thank you. I don't see any other questions at this time. So thank you once again for presenting on an excellent topic that many of us have a great interest in. We will take a short break for 5 minutes and we'll be ready, for our next speaker. Thank you.
Thank you.
Okay, welcome back, everyone. Our next topic is on inflammation, the complexities, critical illness, and nutrition support considerations. Our speaker is Dr. Adina Hirsch, who's a senior medical science liaison for medical affairs and parental nutrition at Fresenius Kabi. She joined the company in 2012, serving the Southeast region. In this role, Adina establishes and maintains scientific relationships with academic researchers, physicians, and clinicians, develops and provides educational materials and presentations, and responds to product and pharmaceutical inquiries. Prior to joining Fresenius Kabi, Adina served as a clinical specialist in the area of nutrition support and critical care at St. Joseph's Hospital in Atlanta, an adjunct faculty member and guest lecturer at Mercer University's College of Pharmacy and Health Sciences, and an assistant professor of pharmacy practice at the Philadelphia College of Osteopathic Medicine. Dr. Hirsch currently serves as immediate past president and newsletter co-editor for the Georgia chapter of the American Society for Parental and Enteral Nutrition. She also serves as the chair of Aspen Chapter Affairs Subcommittee and is a member of the Aspen Membership Committee and the Georgia Society of Health System Pharmacists Education Committee. She also serves on the Florida chapter of the American Society for Parental and Enteral Nutrition Subcommittee and was a finalist for the MSL of the Year for 2019 and 2020 with the MSL Society. Adina received her Doctor of Pharmacy degree from the College of Pharmacy and Health Sciences at Mercer University. I think I went over some of this earlier. She spoke last year as well on a very excellent topic that we all enjoyed. So welcome, Adina.
Thank
as
you.
our next presenter.
Thank you very much for the introduction. And can you see my slides?
Yes, we can.
Excellent. Thank you so much for inviting me again to this symposium. And today's topic is going to be about the complexities, issues with critical illness and nutrition support considerations with inflammation. So as was just said a few minutes ago, I am an employee of Fresenius Kabi as a medical science liaison. However, being that this is a CE presentation, we will not be discussing any products or promoting the use of any specific products. So our objectives you have in your handout here. So in the interest of time, I am not going to read them to you, but they are available in your handout. So let's just start with a little bit of background on inflammation. And the definition of inflammation, if you look in the dictionary, is it means to set on fire. It's from Latin, which is to set on fire. And interestingly, in one of the oldest medical writings that's available today, which it's a textbook de medicina, which was published around 30 AD, they discussed the definition of inflammation as redness, swelling, heat, and pain, which is changed a little bit today, but it's pretty much very pretty similar. Then in the 19th century, Rudolf Virchow, who was a German physician and oncologist and did a lot of inflammation research as well, he noted that inflammation was actually a predisposing factor for cancer and for tumorigenesis, and added another cardinal sign in addition to the four we discussed as loss of function. So looking at some more medical definitions, again, pretty similar, a localized reaction that produces redness, warmth, swelling, and pain, gives you a reason, though, as a result of what? As a result of infection, irritation, or injury. And it notes that it can be either external or internal. It's basically our body's response to some kind of perceived harmful stimulus. So generally, this is a very good thing, right? If you get a bacterial infection or even a splinter, we would like our immune system to jump on in, get rid of that offending agent and clear everything up. Unfortunately, sometimes we can have with the case of autoimmune diseases, our immune system kind of feels like it's detecting and triggering an inflammatory response when there's nothing there. And again, so it's turning our body's protective immune system on our own tissues. And again, it's responding as if our tissues are abnormal or infected. So now we're going to just talk a little bit about properties and response progression of inflammation. So since that original definition back in the year 30, so almost 2000 years ago, we've come to realize that the inflammatory process is very complex. And again, it is a response to that tissue damage and or infection, and it's protective, right? We want to, it has a role both in defensive and healing properties. It's diverse. We can have acute inflammation, which is not necessarily a bad thing, chronic inflammation, which is not a great thing. And what we've also noticed is before that definition said it's a localized reaction. It can be a systemic reaction as well. What is the goal of inflammation in a normal situation? It's reinstatement of cellular homeostasis. So we want to get rid of whatever it is that's causing that injury and then resolving the consequences of that injury, getting rid of those necrotic cells and helping repair the tissue. As time is going on, this is still an evolving definition. Even 2000 years later, we are discovering new things about the immune system. It's much more complex than we originally thought. And because we are learning more about the properties and the progression of inflammation, there may be some new treatment targets as well. And we'll see that even with nutrition, there's some new treatment targets. So it is more than a localized reaction. It's very complex. So how does our immune system regulate inflammation? So this is just a high level overview, okay? So what happens first is our host, we recognize that there's some kind of offending agent, be that a tumor cell, be that an infection, or a splinter. Then, so the body recruits leukocytes and plasma proteins, activates them. These then in kind destroy and get rid of that offending agent, and then you have repair of the damaged tissue. So kind of looking at the different phases of this acute inflammatory response is, I mean, anybody who's gotten a splinter or smashed their hand in a car door knows that you'll get that edema immediately. You know, you'll feel that immediately, seconds to minutes. Then you have the recruitment of these neutrophils. That's within a couple of minutes. And then you start getting monocytes and macrophages in a matter of days. So what we have is the initiation of inflammation, which is get that blood flow increasing, get more vascular permeability, recruiting those leukocytes, activating those leukocytes. And then what we want to happen is then resolution. So reverse to our homeostasis, decrease the vascular permeability, repair the tissue. So just showing this in, again, in another graphic here, this is kind of what we just talked about, right? There's some kind of damage. You have that acute inflammatory response, eliminate the offender, injury, repair the injury, and inflammation's resolved. So that is how it's supposed to be. What if you don't clear the stimulus? Then you're going to get chronic inflammation. What's another way we can have chronic inflammation? Some hypersensitivity diseases, autoimmune diseases, prolonged toxin exposures. Then you have chronic inflammation. So what can we do there? Well, we can treat the disease, remove the stimulus, and then you have resolution of inflammation. If it's not, however, then we have these non-resolving consequences, and you have that persistent chronic inflammatory state. So chronic inflammation, it is characterized by this prolonged inflammatory process, which could be weeks to months to actually years. And it's the cause for it, again, is we haven't eliminated that whatever stimulus it is that was triggering our inflammatory process. And also the inflammatory process itself can cause further injury. So, and the effects on this could be major damage, either caused by the persistent trigger or by our own host inflammatory response. So, and that is what we want to minimize if we can. So let's go back to the beginning of inflammation just to look at these mediators of inflammation. So you can see there's lots of them. There are vasoactive amines, are cytokines that we've all heard about. So vasoactive amines, histamines, they help increase permeability and dilation. Serotonin is a vasoconstrictor. We're not really sure what its role in inflammation is yet. Cytokines are these very small proteins, and they are involved in cell signaling. They can be pro-inflammatory and anti-inflammatory, but when we're initiating inflammation, they're going to be pro-inflammatory. And here's a list of some of the pro-inflammatory cytokines and chemokines that are involved in inflammation initiation. Then we have arachidonic acid-derived eicosanoids, and those actually are derived from fatty acids. So that's why we have those kind of, we're going to talk about those more. So I've bolded that for you. And these arachidonic acid-derived eicosanoids mediate almost every initiation phase activity with inflammation. There are two different pathways. There's the COX pathway, which is cyclooxygenase pathway, that gives rise to prostaglandins and thromboxanes that are pro-inflammatory. And then there's the 5-LO or lipooxygenase pathway, which gives rise to other pro-inflammatory mediators such as leukotrienes and hydroxyeicosatetranoic acid. We also have our complement system that enhances our antibodies and phagocytes, and then our ROS, reactive oxygen species, that help destroy whatever it is that has invaded us, right? A bacteria, for example. But one of the downsides of these ROS, they can also damage normal tissue. They don't really know what's normal and what's not. So let's look a little bit more into the fatty acid metabolites and their role in the inflammatory process. So this is a little bit of a busy slide, so I want to just orient you to this. So we have two essential fatty acids, humans do. Alpha-linolenic acid, which is an omega-3 essential fatty acid, and linoleic acid, which is our omega-6 essential fatty acid. We also have omega-9s here. However, they are non-essential fatty acids, and they're not involved in the immune process or the inflammatory process. So there are some downstream products of ALA, which is the omega-3, and LA, which is our omega-6 essential fatty acids, that are very active in the inflammatory process. So arachidonic acid, there's EPA, actually DPA as well, and DHA. So let's look at arachidonic acid first, because that's really the one that's involved with inflammation activation. So arachidonic acid gives rise to these potent pro-inflammatory eicosanoids, and these are the prostaglandins, thromboxanes, and leukotrienes that we talked about. It also has a little bit of anti-inflammatory activity, so it's not all pro-inflammatory. But you'll see also EPA, which is kind of a structural analog of arachidonic acid on the omega-3 side, also gives rise to these inflammatory eicosanoids, but they're weaker. And those are your odd series prostaglandins, thromboxanes, and leukotrienes. So the way that I remember which ones are weaker and which ones are stronger, we all kind of know that omega-6s have a more potent pro-inflammatory profile. So omega-6 is even. So our even series eicosanoids are more potent pro-inflammatory, whereas omega-3s, weaker pro-inflammatory. So our odd series eicosanoids are less pro-inflammatory. But there's something that has been described within the last 20 or so years, which are SPMs. So these are specialized pro-resolving mediators, and it's just like what they sound like. They are pro-resolving. So as opposed to being pro-inflammatory, these are pro-resolving mediators. And these arise from EPA and DHA. And actually, recently, we found some, not we, I wish we would be getting a Nobel Prize, but this was Dr. Suran from Harvard, has discovered also some SPMs from DPA as well, which is another metabolite of alpha-linolenic acid. So what these SPMs do, they help resolve inflammation. And we'll talk about that a little bit more in the next couple slides. So again, let's look back at these arachidonic acid-derived eicosanoids. Eicosanoid is just a fancy word for 20 carbons. Okay, so they are bioactive mediators that come from this 20-carbon fatty acid or arachidonic acid. Again, that's arachidonic acid is a metabolite from our omega-6 polyunsaturated fatty acids, and we get it either from our diet, from arachidonic acid in our diet, or from linoleic acid, which is also from our diet. Because that is an essential fatty acid, we are incapable of synthesizing this. So all of this is coming from our diet. And you can see the activities of these different eicosanoids from arachidonic acid involved in the inflammatory process. So vasodilation, smooth muscle contraction, vasoconstriction as well, increased vascular permeability, and chemotaxis, leukocyte adhesion, which all play into that initial inflammatory process. So what about resolution? So it used to be thought that resolution of inflammation was just a passive process, that once inflammation was resolved, then it just went away, right? Now what we've learned is it's actually an active process whereby there's a decrease in these pro-inflammatory mediators and an increase in these SPMs. And how does this come about? There's something called lipid class switching. So these prostaglandins that we had at inflammation of initiation, so again, those are pro-inflammatory. They're actually activating the enzymes that then activate the pro-resolving mediators. The synthesis of pro-resolving mediators, those are derived both from omega-6s and omega-3s, much more from omega-3s than omega-6s. They also will help differentiate our macrophages from a pro-inflammatory phenotype, which is M1, to an anti-inflammatory phenotype, which is the M2 phenotype. And what does that do? Those macrophages then help clear all that debris that we had from this insult, help initiate tissue repair, and secrete mediators of homeostasis like IL-10, which is an anti-inflammatory cytokine and vascular endothelial growth factor. So again, our SPMs, they can stop that infiltration of our neutrophils. They're counter-regulatory to those pro-inflammatory cytokines and chemokines. They can even reduce pain, and they switch our macrophages from a pro-inflammatory to an anti-inflammatory action. They work again on both our neutrophils and our macrophages, and they're all derived from our polyunsaturated fatty acids. So again, most of them from our omega-3s, EPA, DHA, and DPA, but also from arachidonic acid. So this is kind of a schematic, just kind of showing you all of this in a little picture. You can see how arachidonic acid, which is again omega-6, really plays into that acute inflammation and, if not resolved, chronic inflammation. But as far as SPMs, you also have a little bit of pro-inflammatory of SPMs from the omega-6s. As you can see, these are leukotriene A4 going to lipoxins, and that again helps with resolution of inflammation and homeostasis. But really looking at the role of omega-3s, much greater here with these SPMs, specialized pro-resolving mediators, so many of them. And again, DPA, that was just something that was discovered a couple of years ago. So putting it all together, we've got our inflammatory process in seconds to minutes. Again, we've got the edema, then we have the neutrophils and the macrophages. Again, this is all mediated by these potent pro-inflammatory mediators. Again, these are all even series, so mostly from that arachidonic acid leading into inflammation. But if things go as they should, then we have this lipid mediator class switching, SPM production, resolution of inflammation and homeostasis. However, if we have unresolved inflammation or dysregulated inflammation, which we can get in either autoimmune diseases or in chronic critical illness, then you have this chronic inflammation, which can lead to fibrosis. Also, if we don't have adequate SPM production, same thing. So what about systemic inflammation? But usually, again, those initial back, 2,000 years ago, even less, even more recently, it was thought to be that it was really more of a local phenomenon. But now we're really recognizing that systemic inflammation can really impact our patient population. So let's look at the no systemic inflammation. That's your normal, healthy individual should have no systemic inflammation at all. Our severely inflamed patients, we kind of know this, right? COVID, acute pancreatitis, trauma, burns, shock, ARDS, SIRS. This is severe inflammation. But look at mild to moderate. I was kind of shocked when I saw this. Stable home parenteral nutrition patients have a mild to moderate level of systemic inflammation. Your stable malnourished patients, anybody with like psoriasis, any kind of autoimmune disease, our preemies are at risk for this as well. Cancer patients, patients with intestinal failure, associated liver disease, stem cell transplant, mechanical ventilation. And this was a Time magazine cover from February 2004, that where they really, this was almost 20 years ago, where they started recognizing the role of systemic inflammation in our chronic diseases, heart attacks, cancer, Alzheimer's. So again, systemic inflammation is something we really need to be paying attention to as well. So here's just some of your learning assessment questions. They are on your handout, so you can put the correct answer. So specialized pro-resolving mediators, do they act on macrophages and induce phenotype switching? Are they derived from polyunsaturated fatty acids? Are they formed via this process of lipid class switching, or all of the above? So the answer is, as you should probably know, it's all of the above. And the next question, this is a little bit tricky. Omega-3 fatty acids are precursors to which of the following SPMs? Resolvins, lipoxins, marresins, and protectins. So all of these are SPMs, but only resolvins, marresins, and protectins are derived from omega-3, or lipoxins are derived from omega-6. So now we're going to talk about the role of inflammation in critical illness. So most of us have heard of SIRS, which is systemic inflammatory response syndrome. And this is due to some kind of major insult that is associated with inflammation. So it can be sepsis, severe trauma, it could be burn, it could be pancreatitis. Consequences of SIRS with these major insults could be multi-organ failure and death. Now in modern ICU care, we're really good at preventing death. We can keep these people alive. But what we're seeing, though, is, okay, we've kept them alive, but a lot of these patients have this immune dysfunction, like they have a hard time recovering from immune dysfunction. So they're either going to go one of two ways, right? They're going to get completely better, or they're going to end up with this persistent immune dysfunction and chronic critical illness, or PICS. So what is driving this chronic critical illness and this persistent immune dysfunction? So there's the role of our cytokines. So we have our pro-inflammatory cytokine IL-6 and our anti-inflammatory cytokine IL-10. Both are extremely important for the initial the IL-6 for the initial inflammation stage. It's kind of like the fire alarm to let our body know that there's something going on. But if it's dysregulated and persistently elevated, it can lead to chronic critical illness. And interestingly enough, it is actually utilized in this nutrition risk assessment score for our patients in the ICU, called the Nutrix score. So it's that is a risk assessment score that takes into account the level of inflammation of the patient. So, and in IL-10, again, good anti-inflammatory cytokine. It limits tissue damage, it restores homeostasis, but dysregulation can lead to immunosuppression and persistent infection. And what they found is, in some studies looking at patients who became septic because of community-acquired pneumonia, those patients that had persistent increased levels of IL-6 and IL-10 had higher mortality than patients whose levels normalized out after the initial insult. So, and what they found with these patients is that these levels were elevated even after they were discharged home. And one study found that increased IL-6 levels after discharge was associated with 1-year mortality. So again, we might think, wow, we got this patient out of the hospital, they're home, or but they're not doing well because of this persistent catabolic syndrome, inflammatory catabolic syndrome. So along with that inflammation, we have that immunosuppression. And this is something called, so CARS is compensatory anti-inflammatory response syndrome. And this is a simultaneous immunosuppression that occurs with that major insult. So it used to be thought that first you had the inflammation, then you had the immunosuppression. They're happening at the exact same time. It's some adaptive response of our immune system, and it kind of paralyzes our macrophages, decreases our response of our T cells, turns our T cell helper cells to a more anti-inflammatory state than pro-inflammatory. And so when you have SIRS and CARs together, you've got these pro and anti-inflammatory cytokines fighting. So you've got your IL-6 fighting with your IL-10. So let's see how this plays out with the stages of acute critical illness. So we have a patient comes into the ICU, major septic episode, COVID's on the rise, so we can use COVID as an example, or pancreatitis or whatever. So you have the patient first comes in, they're in some kind of septic shock. First couple of days, very catabolic, very metabolically unstable. Then there's a later acute phase. Now, again, days 1 and 2, 3 and 7, that's just an example. Nobody really knows. There's no real cutoff for, oh, well, they're in day 3, so they're in the late acute phase. The early acute phase could be 4 days. We're not 100% sure, but this was just a schematic from the European Society for Parenteral and Enteral Nutrition guidelines from a few years ago. So by the late acute phase, which is around sometime in the first week, your patient's a little more stable. Maybe they're on stable pressors or they're getting off of pressors. So a little bit less unstable, however, still very catabolic. And that's when we start seeing a lot of this severe muscle wasting. So then we have this post-acute phase where you're going to go one of two ways. You're either hopefully improving, going to rehab, becoming anabolic, or you're ending up with this persistent inflammatory catabolic state, which is called PICS, not to be confused with post-ICU syndrome, which is another acronym for PICS. And it's kind of defined as around more than 14 days. And again, very catabolic. And what is driving this, all of this acute critical illness? It's this inflammation that's driving this. So this was a really nice schematic that is from Gainesville, from Shands in Gainesville. They've done a lot of work looking at this persistent inflammatory catabolic syndrome. So this kind of just sums it up, what we just talked about. So you have some kind of major insult. It could be a car accident. It could be sepsis. It could be a pneumonia. It could be pancreatitis. And you've got one of three ways that this is going to go. So initially, you've got this pro-inflammatory and anti-inflammatory process happening at the same time. And you're either going to go early multi-organ failure and a pretty quick death, or you're going to be a rapid recoverer. So within less than 2 weeks, patient's better out of the ICU, or there's going to be this persistent inflammation and progressive immunosuppression, leading this patient into this chronic critical illness that is that's characterized by a lot of protein catabolism and cachexia and very complicated outcomes. And you can see there on the y-axis, they put that ICU day 14 is around where you're going to start seeing them go from either rapid recoverers to the persistent inflammation with that PIC syndrome. Again, 14 days is not carved in stone, but it's around 14 days. And those are those patients that are just languishing in our ICU. So definition of this chronic critical illness or PICS is they've survived that initial episode. So they came in with severe septic shock. Now they've survived it, but they're still in our ICU for at least over 14 days, and they've got some kind of organ dysfunction. So what are some of the features of this? We're seeing respiratory failure. They're dependent on mechanical ventilation for a really long time. Lean body mass is decreasing. Their functional status, quality of life is decreasing. Their wound healing is very poor, and they're losing weight. So that's either they have a BMI of less than 18, or they've lost more than 10% during their hospitalization. We're also seeing these biochemical changes, the immunosuppression and the inflammation that we just talked about. That's why, again, we don't really want to look at prealbumin levels in these patients because they're going to be low. You've got that elevated CRP, which is prealbumin is a negative acute phase reactant protein. CRP is a positive acute phase reactant protein. CRP is going to win. Prealbumin is going to be low until they get better. Don't even check it. And then you've got also subsequent endocrine dysfunction. And it's, again, associated with this malnutrition. And it's not just malnutrition, it's almost this cachectic state. And it's really, we don't have a lot of effective interventions currently. It's hard to stop it. It's hard to slow the progression of it, even if we're giving adequate nutrition support. There's not a whole lot of literature about nutrition support in PICS, although it's starting to pick up a little bit. And we're going to see those metabolic alterations, which we'll talk about in a couple slides. However, it does mimic some other disease states. So maybe we can draw on our experience with other disease states to give similar nutrition support treatment. So it kind of looks like mimics aging sarcopenia. What do we want to do with that? We want to give them a good amount of protein, make sure they're doing some resistance in aerobic exercise. Even though you think, well, they're in the ICU and they're intubated, how are we going to do exercise? You can do it. We can get these patients up and walking, or at least on a stationary bike or something like that. Major burns, what do we do there? Anabolic supplementation, good glucose control. And cancer cachexia, again, that anabolic supplementation and possibly immunonutrition. So these are things we can consider to try and mitigate the effects of PICS on our patients' nutritional status. So let's just look at cancer cachexia, because I think it really shows the role of these pro-inflammatory cytokines on our nutritional status. So this is from an article that was published from Todd Maddox in the Nutrition and Clinical Practice about 6 years ago. And it talks about the role of inflammation in cancer cachexia. So you've got your tumor, and you've got two different factors that are playing in here. We've got the tumor factor or factors, and then we also have our pro-inflammatory cytokines. And that's what I really want to focus on. So what do these pro-inflammatory cytokines do? They increase our REE, our resting energy expenditure, and our acute phase protein synthesis, like CRP. Induce anorexia. You've got some hormonal changes, more serotonin, less ghrelin. Effects on lean body mass, decreasing lean body mass through increased proteolysis, decreased protein synthesis, increased gluconeogenesis from our amino acids. And then we also have increased lipolysis, decreased lipogenesis, and increased insulin resistance. So notice this is all just from these pro-inflammatory cytokines. And so that's why we could maybe extrapolate this to what's going on with acute and chronic critical illness. Now, our tumor factors also play in here, but again, notice that they play in a little bit, but not as much as our host factors. So what are the metabolic alterations we see in PICS? Again, just like with cancer cachexia, increased resting expenditure, increased glucose production, but with that insulin resistance, okay? And because we don't have a lot of glucose reserves, now we're going to be using protein, breaking that down so we can use our amino acids for gluconeogenesis. Protein, we've got that progressive skeletal muscle breakdown, and really very hard to get a neutral or positive nitrogen balance. And with lipids, we're not clearing it well, but we're having increased lipogenesis and hepatic triglyceride production. And I know that in the beginning of the COVID pandemic, I was getting calls from all of my colleagues that were on the front lines, and they were like, we don't know what's happening with these patients. Their triglycerides are through the roof. We don't even have them on any propofol, and their triglycerides are so high. And that was just that these metabolic alterations we were seeing with acute inflammation. So this was a paper that came out in 2020 out of Duke, where they were looking at the hypermetabolism in these very, very inflamed patients with COVID-19. Again, this was back in 2020. We really didn't have anything in our arsenal to treat these patients, just learning about it. But they were looking at, well, what are their energy needs? Okay, so they did indirect calorimetry measurements, which is the gold standard, over a period of 3 weeks. And it was a small study, but notice that most of the patients were obese, and the age ranges were pretty wide. And looking at this chart here, what you could see is early on, so from day 0 to 7, pretty hypometabolic, right? Around 18 to 20 kcals per kg. Again, this is per indirect calorimetry. By day 7 to 14, they're more normal catabolic. So 21 to 26 calories per kilogram. But let's look at days 14 to 21. So now we're in chronic critical illness territory. look how hypermetabolic these patients are. They are, and even our obese patients, looking at actual body weight, are needing between 25 and 36 calories per kilogram actual body weight. Very hypermetabolic. So it shows, but also you can see there's a large range, okay? With all the patients, they were needing between about 1,800 to 3,300 calories. And it's very hard to use predictive equations to figure this out. It just also highlights the importance of indirect calorimetry if you can get it in your institution. So let's start with a case here, a case presentation. So we have a 58-year-old female. She's admitted with severe acute pancreatitis. She had an alcohol problem. It's now hospital day 3. She's intubated. She's sedated. She is meeting all SIRS criteria. She's got ARDS and acute kidney injury. Her past medical history is positive for heart failure, alcohol abuse. She's also a smoker. Her height is 155 centimeters, 55 kilo. BMI is normal, 22.9. Looking at her diet history, again, from her family, she didn't eat a whole lot. She usually skips lunch, just a little coffee for breakfast. She does have dinner with her family. So what phase of critical illness is this patient in currently? So she's hospital day 3. She's definitely in the acute phase. Is it the early acute phase? Is it the late acute phase? She's kind of in between, but she's definitely in an acute phase. She's been only in the hospital for 3 days, and she has this multi-organ failure. So is she likely to be hypometabolic, normometabolic, or hypermetabolic at this stage? At this stage, again, we don't have indirect calorimetry yet, but I would say she's probably hypometabolic. So we want to start feeding her, but we're going to want to start slow. And we'll see, there's a really, Duke came out with another study that we're going to look at in a few minutes that kind of guides you as to how to start feeding these patients. So now we get to talk about our nutrition support considerations for these patients. So earlier, when I was talking about IL-6, I mentioned this NUTRIC score. So NUTRIC stands for Nutrition Risk in Critically Ill Score. And this score has been validated. And what it helps you do is to quantify the risk of your ICU patient developing adverse events that we may be able to modify with aggressive nutrition therapy. So it's scored from 1 to 10 based on 6 variables. So SOPA scores, Apache scores, comorbidities, age, how long have you been in the hospital, but also IL-6. So inflammation plays in to this risk of a patient developing adverse events that maybe we can modify. They have also validated it without IL-6, and in which case a score of over 5 would tell you that it's high risk. And the reason they validated it without IL-6 is, I don't know about you, but when I was working in the hospital setting, IL-6 was a send out. So by the time you get this back, your patient's probably chronically ill, all better, or dead. So it wasn't very helpful. So it's nice to know that this has been validated without IL-6. And again, these patients that have these higher risk scores they have higher increased mortality and longer duration of mechanical ventilation. So what can we do to support these patients nutritionally? So what about enteral nutrition? Early EN, it's not going to prevent this ongoing catabolism, but it still has value. And what can the early enteral nutrition provide our patient? It can help them maintain their gut integrity. It helps decrease gut permeability. It can help maintain and upregulate our immune function because our GI tract is one really big immune organ. It's also associated with lower hospital length of stay, infectious morbidity, and mortality. So early EN is always the way to go if you can go. So what do our Aspen guidelines say? Start EN early, within 24 to 48 hours. If you're unable to maintain volitional intake, there are some guideline bundle statements from the 2016 guidelines, and they do discuss chronic critical illness. And they state that at this point, once that patient's in that stage of, languishing in your ICU for around 2 weeks or more, aggressive high protein enteral therapy and resistant exercise when possible. And again, protein, you might need up to 2. And we're going to see from the Duke study, you may even need more. What about these immune modulating enteral formulas? So initially in 2009, when the first Aspen SCCM guidelines were published, they had a level A recommendation for some of these products for ARDS, That was reversed in the 2016 guidelines. And these immune modulating formulas, one of the difficult things with them is they have so many things in them. So is it the arginine? Is it the glutamine? Is it the omega-3? Is it the GLA? Is it the antioxidants? We don't know. But Aspen guidelines, and this is again for critically ill patients, they don't recommend routine use in your medical ICU. They do say that you can consider it in traumatic brain injury or your perioperative SICU patients, and they no longer make a recommendation for routine use in patients with ARDS or severe acute lung injury. And the reason for this downgraded recommendation is there was a lot of heterogeneity in the population study, and there were inconsistent outcomes that could be more condition specific. That's why there's more of a recommendation for your perioperative trauma and less for your MICU. But thinking about inflammatory states, cancer, right, is in an inflammatory state, as we saw several slides ago. So this was a meta-analysis that was published in 2020, meta-analysis of 61 randomized controlled trial in your surgical cancer patient population, where they looked at immunonutrition versus standard nutrition. Most of the studies were enteral. You could see 43, actually 49 had some kind of enteral component, 12 had only parenteral nutrition, and you can see the different immune nutrients they looked at. What they did find, again, this is in this surgical cancer population, about a 30% decrease in post-op infectious complications, including wound infection, respiratory infections, and UTIs, 30% decrease in anastomotic leakage, decrease in length of stay, but a lot of heterogeneity there, so grain of salt. And again, they did some subgroup analyses seeing, well, what is it that helped? And it's mostly just that immunonutrition. It wasn't, some of them showed, well, omega-3 alone, but most of them were some kind of combination of these immune nutrients together. So that's another limitation, is we don't know what it is. Is it all three together or four together? We're not 100% sure. So there is a role of these immune enhancing formulas in certain inflammatory states, but not necessarily right now in critically ill. The European guidelines don't really talk about that either, if I recall. So what about a parenteral nutrition? So the Aspen SCCM guidelines in 2016, they said, well, wait for 7 days to start PN in the ICU. If they're in high nutrition risk, maybe you could start it earlier. But in 2022, and this was actually a high level of evidence and a strong recommendation, there's really no difference between starting early enteral or early parenteral regarding clinical outcomes. So you can feel safer if you have a really malnourished patient and there's just no way you can start enteral nutrition in that first week or so, you can start early parenteral. Now, let's say you've started enteral, but they're just not up to goal yet, and you're having a hard time getting them up to goal. So as far as supplemental parenteral nutrition, the new 2022 guidelines said, wait at least 7 days if you're going to be adding parenteral onto enteral. And again, this was, again, a high level of quality of evidence and a strong recommendation that you can wait about 7 days for that. But what I think is very important that wasn't specifically stated is after 7 days, everybody needs to be getting 100% of their goals. So don't wait too long to start that supplemental PN if they're not tolerating enteral at goal. Protein requirements 1.2 to 2, up to 2.5 in CRRT. And as far as lipid considerations, again, the composition may influence the inflammatory response, so consider that. So this is the Duke study that a year after they came up with that study with showing the hypercatabolism in these COVID patients, they came up with a nice ICU nutrition algorithm that was, again, indirect calorimetry guided, but they kind of let you know what you should be doing even if you don't have indirect calorimetry. So again, that acute phase, which they define as days 1 to 4, start early EN or PN, and then progress towards your target while preventing overfeeding. We never want to overfeed these patients. So you could start at about 25% of their goal by day 1, and then by day 4, getting up to 100% of goal. And that post-acute ICU phase, which they define as after day 5, you want to get to at least 70% of their predictive equations or of indirect calorimetry goal, minimum protein of 1.3, that comes from the European guidelines. And notably, if you can't get that patient to that full goal or close to 80-85% of their enteral, then add some protein modulars. At least get their protein a little higher, even up to 2 grams per kilo per day. But what I want to focus on here is this post-ICU phase and post-hospital discharge. These patients are still inflamed and they're hypercatabolic. And look at what they're recommending for post-ICU phase. So once they're up on the floor or they're even outside, they need more than 100% of their indirect calorimetry, up to 40 calories per kilo, and up to 2.5 grams per kilo per day of protein. So you want to consider prolonged enteral, ONS, protein supplements. Don't forget about these patients when they leave your unit, because they are still in need of a lot of nutrition. So here's our patient again. So what are we going to do with her? Should we start, she's day 3, should we start nutrition support? And by what route and how many calories? So absolutely, we want to start feeding within 24 to 48 hours. So we really are almost behind the 8 ball here. She's obviously not able to take sufficient PO. She is intubated. And how much are we going to feed her? We're going to give her enteral nutrition. There's no contraindications to enteral nutrition, and hypocaloric. So 25 to 75% of her REE. Hopefully, if we have indirect calorimetry, that's great. Otherwise, let's use some predictive equations. But we want to get her to goal by the end of that first week, and really even by day 4 or 5. So now let's look at some immune nutrients and see if there's anything we can do to help resolve in the inflammatory process with these immune nutrients. So omega-3 fatty acids. Again, we talked about this before. They're precursors to these weaker pro-inflammatory mediators and our SPMs. So they have, and again, they're provided in the form of fish oil, either given enterally or parenterally. And so we have an adequate intake that from the Institute of Medicine that says for men and women, it's like 1 to 1.6 grams per day. Our patients, probably in our diet, we're getting in milligrams per day. We're probably not getting enough. I do like to eat a lot of fish, so I think I'm getting a lot of the downstream products. Minimum EPA and DHA at least 0.25 grams per day. That's EPA and DHA together. And they found that dietary consumption intake of our fish oils is kind of dose responsive. So healthy patients should be getting at least 2 grams a day. Rheumatoid arthritis, there are actually studies showing that 3.5 grams per day of fish oils is associated with some improved outcomes. So what is the therapeutic utility? Is it the prodrug? Are we eating fish oil or taking in ALA for the SPMs? Or is it a nutrient? Still 100%, not 100% clear. We still need to have dosing established for certain disease states. However, for the critically ill and surgical patient populations, there have been some data showing that 0.1 to 0.2 gram per kilo per day of fish oil in a lipid emulsion, at least, is associated with improved outcomes. So there's a bunch of disease states, inflammatory diseases, that could benefit from this, including our autoimmune diseases, hypersensitivity diseases, metabolic, genetic, age-related even, as well as these acute insult, our SIRS patients as well. So there were a bunch of meta-analyses, about I think 12 or 13 of them from 2010 until 2023. I think the last one was published, and looking at either your surgical patients, either in the ICU or not ICU, and your ICU and critically ill patients. You can see the fish oil doses provided. This is using fish oil containing lipid emulsion. So this is in parenteral nutrition. They're about that 0.1 to 0.2 that are recommended in the European guidelines. And what they found in these meta-analyses are statistically significantly decreased infectious complications. One meta-analysis showed decreased sepsis risk, shorter hospital and ICU length of stay in both your surgical and critically ill patients. Looking at some non-clinical outcomes, looking at those inflammatory markers. So if you're leukotriene B5, remembering that our odd series Icosanoids are your weaker pro-inflammatory, and the even series are pro-inflammatory. So if that ratio is going up, it means you're going towards a weaker pro-inflammatory profile. So that goes up. Some of the studies have showed decreased IL-6 and TNF-alpha. Other studies have shown no difference. So studies are kind of mixed as far as effect on inflammation, inflammatory markers. But just looking at all of the meta-analyses from 2010 until 2022, you can see that the statistically significant clinical outcomes pretty much consistent as far as decreased infections, ICU length of stay, and hospital length of stay. Only a few of them showed no difference. So what about glutamine? So glutamine is a primary fuel for enterocytes, lymphocytes, and macrophages, so very important in our immune response and inflammatory response. It's a substrate for gluconeogenesis, glutathione production. It's considered a conditionally essential amino acid during stress, and it's a precursor for renal ammoniogenesis. So the big question, especially in the ICU population, is glutamine safe? And the reason that we're worried about safety with glutamine is a study that was conducted back, it's about 10 years ago, called the REDOX study, and that stood for reducing deaths due to oxidative stress. And this was an RCT, double-blinded, looking at over 1,200 ICU patients that had multi-organ failure, and they gave glutamine with or without antioxidants versus placebo. Now, the dose of glutamine was really high because that 0.5 gram per kilo per day IV is the recommended dose IV, and the 30 gram oral or enteral per day is the recommended dose for oral. So they kind of gave a double dose. Their primary outcome was 28-day mortality, and there was actually a trend to increase mortality in the glutamine arm versus placebo, pretty strong trend, P of 0.05. And so again, we talked about the criticism of this trial design. The glutamine dose was really, really high. So the Aspen SCCM and surviving sepsis guidelines say you really shouldn't use it routinely in your ICU patients, and don't use it in patients with sepsis and septic shock. But that doesn't mean you shouldn't be using it in any patient population that may have a pro-inflammatory process going on. So using cancer, again, as our example, this was another meta-analysis that was published in 2020, looking at this 27 RCT, almost 1,500 cancer patients who were undergoing radiotherapy plus or minus chemo, and that were receiving some kind of immunonutrition. You can see a vast majority of studies were enteral. Most of the studies had glutamine. Only one study did not contain glutamine. So what they did find was significantly less higher grade esophagitis, mucositis, and diarrhea, and of interest, significantly less weight loss in the immunonutrition group. So 68% decreased risk of weight loss in that group. So again, when you're looking at these data, glutamine is just a little iffy right now in the ICU population, but outside of the ICU population, there may be a role. And what about arginine? So that is also another essential amino acid in stress. When our endogenous supplies are low, arginine is degraded by an enzyme called arginase 1, which is increased significantly during critical illness, surgery, trauma. So where do we get our arginine from? We get it from our diet, but even more from endogenous synthesis from protein or turnover and citrulline. What does arginine do? It's an immune function modulator. It helps with lymphocyte proliferation and differentiation, macrophage differentiation. It's also a substrate for nitric oxide production that makes people a little nervous using it in sepsis. And we do see that a deficiency of arginine in our critically ill patients can cause T lymphocyte suppression, so immune suppression, decreased CD4 cells, increased inflammatory markers, and associated with increased infection in critical illness. So, is arginine safe? So Dr. Rosenthal, this was from Shands in Gainesville. They're the ones who had that wonderful PICS paradigm. They actually did a review about looking at the safety and efficacy of both parenteral and enteral arginine. And they found that when supplied at doses that were provided in these commercially available products, it's safe. At doses at least up to 30 grams per day, and maybe even higher, up to 40. If you're giving it as a bolus without other macronutrients orally, if giving it high doses, you might see some GI upset. They stated that in PN, it appears to be safe at clinical levels. And they stated that it's clear that it's safe in our septic patients. Further research needed about, well, what's the optimal dose? Should we be giving it IV? Should we be giving it orally? But Aspen and SES and SCCM surviving sepsis and the surviving sepsis guidelines, the Aspen SCCM actually says it is not contraindicated in sepsis or septic shock, but you should avoid routine use in your medical ICU patients. Again, consider it for severe trauma and traumatic brain injury. This is consistent with what they said about the immune enhancing formulas as well. The surviving sepsis guidelines say maybe you don't want to use it in your septic shock patients because of that concern for vasodilation and hypotension, which I'm not sure if it's really panned out in a lot of studies. It's more of a academic concern. And finally, probiotics. Love our probiotics, right? So what are those? Live microorganisms that, when they're administered in adequate amounts, can confer a health benefit to the host. So what can they do in our inflamed and our critically ill patients? It can suppress the growth of pathogenic bacteria. It can block attachment of these pathogens to our epithelium. That's more of your lactobacillus. Enhances mucosal function, microbial barrier, lowers the colonic pH, which makes it very unhappy for our pathogenic bacteria. They are competitively consumed nutrients that are required for our pathogens, and they modulate the immune response. So they can decrease those pro-inflammatory cytokines and help increase the release of anti-inflammatory cytokines. So I was not able to find a real good study looking in our critically ill inflamed population, but let's look at chronic inflammation. So this was a study that looked at the effect of different medications and different nutritional supplements on these patients, on our aging populations with chronic inflammation. So again, they were looking at CRP and IL-6 in our middle-aged to older adults with that low-grade chronic inflammation. So what they found is these medications, our angiotensin receptor blockers and metformin, were helpful. Omega-3s decreased IL-6 and CRP, but the largest decrease in IL-6 and CRP was with probiotics versus all of the other compounds that they looked at. And of note, vitamin D and resveratrol, which is from grapes, there was no significant changes in inflammatory markers that they looked at. So what about probiotics in the ICU? Aspen says seems to be safe, the ones that were studied. But again, pay attention to the studied probiotic species. Not all probiotics are the same. So if you're reading a paper and it's like, wow, the probiotics really worked, make sure that you're looking at specific probiotic that they were using in that study. They recommend using it only for select patient populations for which RCTs have documented both safe and effective outcome benefit. They don't recommend it for routine use, not a high quality of evidence. The surviving sepsis guidelines and the European guidelines don't even talk about probiotics. So this is all we have. So let's go back to our patient. She's now ICU day 10. She's been intubated since day 1. She's sedated. She's not on propofol, still meeting criteria, still's got multi-organ failure. She's lost 4 kilos. So since she's been admitted, she's been getting enteral nutrition since day 3 when we started it. We started with the standard formulation, but she's not tolerating it well. So we switched to a semi-elemental formula that has arginine, omega-3s, nucleotides at 20 ml an hour, but we're still not able to advance it past 20 ml an hour. So what are we going to do? Well, supplemental parenteral nutrition. Let's try a fish oil containing lipid emulsion with those SPMs. Goal 100% REE, minimum 1.3 gram per kilo per day of protein per the Duke protocol, making sure she's getting 100% of her REE. Try additional measures to enhance enteral tolerance, whatever we can do, maybe post-pyloric placement. And if she starts languishing in the ICU for more than 14 days, which seems like she might be going there, then we might want to even think about higher protein, higher caloric provision. If we could get indirect calorimetry, that would be fabulous. So what are some future directions? So as far as nutrition support approaches, there are some companies, they're not FDA approved, but they're actually developing these SPMs. So you don't just take the fish oil, you can take actually an SPM. And they obtain this through purified extracts of omega-3s from fish oil. Also leucine, it's another amino acid. So we talked about glutamine, we talked about arginine. Leucine is a branch chain amino acid. It is essential. It's involved in skeletal muscle synthesis. So this might help with protein synthesis and decreasing protein breakdown, stimulate anabolism, and stimulate some enzymes that increase mRNA synthesis that help promote protein synthesis. So these are some things that just keep your eyes open for this. There may be some studies coming out on these. As far as pharmacologic treatment, standard of care, NSAIDs and glucocorticoids. What is the best thing that we had with COVID? That high dose Decadron, dexamethasone. There are some targeted therapies for chronic inflammation, our anti-TNF agents, cytokine inhibitors, etc. All those biologics that are coming out there that every time you turn on the TV, there's at least 16 commercials about it. And it's what about targeted therapies in critical illness? Something that could block that pro-inflammatory response or at least moderate it. We want to have a pro-inflammatory response initially. We just don't want it to go haywire. So there have been a lot of experimental therapies for COVID. That may be something that we could look at for our inflamed critically ill patients who don't have COVID. Clinical trials using those therapies for chronic diseases have not really proven successful. There was another product that was out there, activated protein C. It was called Zygris. That was withdrawn from the market over 10 years ago. What's mostly important is this multidisciplinary approach is key. We have to better understand SIRS and CARS and the inflammatory process. Looking at genetics and molecular biology, can we identify patients who have a predisposition to chronic inflammatory diseases? Developing new targets as we learn more about the immune system. As far as nutrition, identify approaches to balance our nutrients in our supplements and try to prevent or at least minimize cachexia that's associated with inflammation. And then maybe we'll be able to actually predict those patients who are going to be those patients with PICS. And if we could predict it, then maybe we can help prevent it. So one last question, which of the following statements about chronic critical illness is correct? Occurs when patients survive an initial insult and are ICU dependent over 5 days, characterized by lean body mass loss, decreased functional status, and poor wound healing, or is it associated with malnutrition that's preventable and treatable with nutrition support? So unfortunately, only B is right. It would be fabulous if C was right as well. And in the interest of time, y'all can read the summary here, and I will open it up to questions. And I thank you very much for your time. Any questions?
03.
I don't see any questions in the
Okay.
chat box, but thank you, Adina, for your very interesting topic on the complexities of inflammation. If there's anything, I don't know if you're getting off the call, but if there's anything after the last speaker, I can.
Yeah, I'll
bring up
stay
the
on until
questions.
the end,
Okay.
so just in case. Okay, thank you.
Thank you. Our last speaker today is Liz Bacon, who will be discussing the global evidence using energy-dense formulas to manage poor growth, and she will provide us with practical tidbits for clinical practice. Liz is a registered dietitian and currently works as a medical science liaison for the challenged growth and GI allergy categories at Nutricia North America. She completed her undergrad degree in nutrition sciences at Baylor University in Waco, Texas, and completed her master's degree in nutrition at Texas Women's University in Houston. Prior to joining Nutricia, she was most recently working at a large teaching hospital in Houston, Texas as a NICU dietitian, and overall has 7 years of NICU experience. As an MSL, she enjoys combining her clinical experience with evidence-based research to support providers caring for at-risk infants. Liz lives in New Braunfels, Texas, with her husband, Matt, and her 2 dogs, Chaco and Earl. Welcome, Liz.
Thank you so much for the introduction, Susan, and for the opportunity, and thank you all for joining this afternoon. So for this presentation, we'll discuss some of the evidence that is collected on energy and nutrient-dense formula in the management of poor growth, some practical tidbits for your clinical practice. So as a disclaimer, of course, Nutritia does support the use of breast milk wherever possible. We know that it is liquid gold, so this presentation will focus on infants that do require formula feeding. So objectives for today, we'll begin by defining malnutrition and describing its current management in infants. We'll then review the evidence on these infants managed with energy and nutrient-dense formula. And lastly, we'll list clinical application of how to use an energy nutrient-dense formula in your practice. So to begin, let's do a quick refresher on what is malnutrition. So the Academy of Nutrition and Dietetics and the American Society of Parenteral and Enteral Nutrition, or ASPEN, defines malnutrition as an imbalance between nutrient requirement and intake, resulting in cumulative deficits of energy, protein, or micronutrients that may negatively affect growth, development, and other relevant outcomes. And so when it comes to infant malnutrition, there's a few different etiologies. First, we have inadequate intake, which could consist of supply concerns if mom is breastfeeding, improper mixing, especially in the presence of concentrating and fortifying formula, reflux, feeding difficulties, neglect and abuse, and acute illness. We can also see malnutrition derived from increased energy needs, and this can be found in patients with conditions such as chronic lung disease, congenital heart defects, renal failure, hyperthyroidism, and chronic infection. And then lastly, we can also see inadequate absorption occur, leading to malnutrition in conditions such as GI-related conditions, cystic fibrosis, milk protein allergy, and inborn errors of metabolism. But overall, we know that inadequate intake is the most common cause of malnutrition in this patient population. In fact, approximately 80% of the time, inadequate intake is the source. And then we also know that some patients have certain risk factors that put them at a heightened risk for malnutrition. These can be medical risk factors such as low birth weight, reflux, congenital anomalies, or acute and chronic illness. And then we can also see psychosocial risk factors such as poor feeding techniques, if mom is experiencing postpartum depression, if there's poverty or abuse occurring at home. And so for the dietitians on right now, I know that for those of you in the pediatric world, this table is likely ingrained in your mind. I know it is in mine, so I won't go through this too in depth, but as an overview, we have a really nice tool available to help us diagnose malnutrition in the pediatric population. And so when we have a single data point, such as a weight for lane Z-score, a BMI for age Z-score for children older than 2, or length for age Z-score or mid-upper arm circumference, we can see here, depending on the Z-score of the patient, we can diagnose with mild, moderate, or severe malnutrition. However, we know that in the real world, oftentimes we have to do a little bit more digging, right, to determine if a patient has malnutrition. So in these cases, we can look to the bottom table, which provides us with when 2 or more data points are available. And this can be weight gain velocity, weight loss for children 2 to 20, a deceleration in weight for lane Z-score, or inadequate nutrient intake. So overall, both of these options provide us with the tool to help with diagnosing malnutrition. And then when looking at the prevalence here in the US, we know that 45% of children with chronic disease are at a heightened nutrition risk. So for those of you who work in the pediatric population, especially in a hospital setting, chances are that the majority of patients you're seeing are at an increased risk. In a primary care setting, we see approximately 10% of these infants with malnutrition. And then for hospitalized infants, it's estimated to be 4% of infants. However, for those of you working in the hospital, you're likely raising your eyebrow at this, saying 4% seems a little bit low, and you're not wrong. This is because this was based off of a coded diagnosis of malnutrition, and we know that oftentimes for many reasons it might not be coded properly, or might not be coded at all. And so the true estimate of this is likely higher than 4%. And then when looking at what the World Health Organization recommends for infants experiencing malnutrition in need of catch-up growth, a target intake is approximately 105 to 126 calories per kilo per day. And of course, there are some infants who will fall below or above this, but this is a nice range to start. And then we estimate that this will provide about 5 to 10 grams per kilo per day of catch-up growth. So historically speaking, here in the US, we have a few different feeding options for these patients experiencing malnutrition. So first, we have the solution of feeding more volume more often. Now, this seems like quite a simple solution, right? But we know for many infants, whether it's due to fluid restriction or poor PO feeding ability, or maybe they tire easily during feeds, simply providing more volume isn't always going to be the best solution. And so in those cases, when we're not able to achieve an increased intake via volume, we can then look to concentrating formula by adding additional powder in order to increase the caloric density of the feed. We can also use a higher calorie formula at a standard concentration. And then lastly, we have the option to start with a base. So this can be maternal breast milk, donor breast milk, or infant formula. And then we can supplement or fortify with modulars or formula in order to increase the caloric density of the feeds. And so for many of you, this may be the first time that you're hearing about energy and nutrient dense formula. So what is this formula? Although it has been used globally since 1999 in greater than 30 different countries, it is relatively new to the US and it's been here for around 2 years or so. So energy and nutrient dense formula is a 30 calorie per ounce term infant formula that not only has an increased caloric density, but also has a higher protein and nutrient content as well. The osmolality is less than 400 milliosmoles per kilogram, so staying well within recommended limits, and of course significantly less than we would see with the practice of concentrating standard formula up to that 27 to 30 calories per ounce mark. This type of formula is ready to feed and it's sterile, so greatly reduces the risk of both infection and mixing error. And then again, it has been used in Europe for 20 years as the standard of care for patients experiencing malnutrition. And so today, for the remainder of the presentation, I'll be sharing the clinical evidence that we have available on this novel formula that we now have here in the US. And so before we begin looking at the evidence, these are the 4 key parameters that were looked at in the research. And these include growth, tolerance, nutritional status, and most importantly, safety. So we have evidence on energy and nutrient dense formula dating back to 2006, with the most recent publication being published in 2021 in JPEN. And so the order that I'll share the evidence in today isn't necessarily chronological order, but we'll go through it in terms of duration of the studies. So starting at the shortest period of time up until the longest. So the first study that we'll looked at protein metabolism using energy and nutrient dense formula, which resulted in 3 different publications. This study was conducted at Maastricht University Medical Center and Erasmus MC Sophia Children's Hospital. And this was a randomized control trial that was double-blinded and lasted for a 5-day period of time. The intervention group consisted of 8 infants who received an energy nutrient dense formula of 30 calories per ounce with a 10.4% protein to energy ratio. Whereas the control group of 10 infants received a standard infant formula of 20 calories per ounce with an 8% protein to energy ratio. Feeds were initiated at 25% of the target volume and advanced by 25% of the target volume every 12 hours until a target of 130 mils per kilo per day was achieved. So overall, there were 18 infants that participated in this study. It is a bit of a small sample size. These infants were all fed enterally and ranged in age from 4 weeks to 12 months. It did consist of a combination of term and preterm infants, but it is important to note that all infants were at least 40 weeks corrected post-menstrual age. And these infants all had a diagnosis of RSV. So when evaluating protein metabolism, they looked at nitrogen balance, plasma amino acid, and stable isotopes, which consisted of whole body protein, splanchnic phenylalanine extraction, and an arginine and citrulline tracer. So we know that the concept of nitrogen balance is the difference between intake via the diet and then loss through ammonium and urea excretion, which can reflect the gain or loss of total body protein. So if we have more protein provided to the patient than is lost, the patient is considered to be in a positive nitrogen balance or an anabolic state. And then when looking at the plasma amino acid, they evaluated 34 to 38 amino acid and intermediary metabolites. And this was able to see if we have, a strong increase of plasma amino acids, we see that there's an issue with breakdown in the body. And this can occur with fever, inadequate nutrition, or in other medical conditions. And then when looking at nutrient intake and tolerance between the two groups, there was no difference in volume. However, we did see that the energy nutrient dense formula group, of course, had a significantly higher intake of caloric energy. And so on average, we had 112 calories per kilo per day consumed by the energy nutrient dense formula group and 82 calories per kilo per day consumed by the standard infant formula group. And then we also see a significant difference in protein consumption, 2.8 grams per kilo per day versus 1.5 grams per kilo per day. And then when looking at tolerance between the two groups, there was found to be no difference in stooling or emesis. And here we can take a closer look at protein anabolism. So looking at nitrogen balance on day 5, the energy nutrient dense formula group had a significantly higher amount of nitrogen versus the standard infant formula group. And we also saw that the energy nutrient dense formula group achieved a positive nitrogen balance as soon as day 2, whereas the standard infant formula group did not have all patients in a positive balance until day 4. And over here on the right, you can see the difference in nitrogen balance between the two groups. So again, we see the energy nutrient dense formula group being significantly higher versus the standard infant formula group. And then when looking at the rates of protein kinetics in both groups, the energy nutrient dense formula group is indicated by the deep purple bar. And so we saw that there was a significantly higher amount of whole body protein synthesis and whole body protein breakdown for the ENDF group. And despite a significantly higher amount of protein breakdown, we still saw a whole body protein balance being significantly higher for the energy nutrient dense formula group. So in summary, this first study and the resulting 3 publications found that use of an energy nutrient dense formula group for patients admitted for RSV helped achieve a positive nitrogen balance in as little as 2 days and promoted anabolism compared to the standard infant formula. There was equivalent tolerance between the two, and most importantly, it was found to be safe and well tolerated in these critically ill infants. All right, so now we will head on over to China, where we will look at the research of Dr. Chui, who looked at the effects and tolerance of protein and energy-enriched formula in infants following congenital heart surgery. This was a randomized controlled trial that was double-blinded and lasted for a 5-day period of time. 5 days was selected as this was the average length of stay that these infants spent in the cardiac ICU following their surgical repair before transitioning to a step-down unit. 26 infants were included in the intervention group, which received an energy and nutrient-dense formula of 1 calorie per mil or 30 calories per ounce with a 10.4% protein to energy ratio. And the control group received a standard infant formula of 20 calories per ounce and an 8% protein to energy ratio. Feeds were initiated according to unit protocol at 12 to 24 hours post-op at 1 ml per kilo per hour, and were advanced by 1 ml per kilo per hour Q6 until their target volume of 130 ml per kilo per day was achieved. So all in all, there were 50 infants that participated in this study. They were fed orally and ranged from 4 weeks to 12 months of age, and all had a diagnosis of congenital heart disease. And these infants were all post-op for biventricular repair, so there were no single ventricle infants included in this study. And then when looking at nutrient intake between the two groups, we saw a higher amount of calories and protein in the ENDF group versus the standard infant formula group, with a significantly higher intake of protein from the ENDF group on day 1. And then when looking at infants who met the adequate intake for both energy and protein, we saw that the energy nutrient dense formula group achieved this as soon as day 2 post-op. Yet for the 5-day duration of this study, the standard infant formula group did not meet the adequate intake. And again, taking another look at nitrogen balance. So we see on day 1 post-op, of course, both groups are in a negative nitrogen balance. Yet as soon as day 2, we see the energy nutrient dense formula group achieve a positive balance, which continues to trend upwards, whereas the standard infant formula group did not achieve a positive nitrogen balance until day 5, which was significantly less than the ENDF group. And we know that for these infants, they're critically ill and oftentimes leading up to surgery for their repair. Growth is a struggle. Volume restriction can be a significant thing, increased metabolic demand. And so being able to support these patients directly after repair is critical in order to achieve that anabolic state. And then when looking at tolerance outcomes, these were the 4 parameters that researchers looked at. They examined intolerable gastric retention, intolerable emesis, intolerable diarrhea, and GI bleeding. So it was found when it came to emesis and GI bleeding that there was no difference in tolerance. However, they did find that the energy nutrient dense formula group did have a significantly higher stool volume on day 3, and it also had a higher stool frequency on days 3 and 4. However, when looking at the 5-day period as a whole, there was no significant difference between the two groups. So we saw this on day 3 and 4. And this can be due to a couple of different things. This type of study formula did include prebiotics. So if they were not receiving prebiotics before, this could lead to some stool changes. And then we also know that they're receiving greater energy and protein. And so what goes in comes out. And so this can also lead to some increased stool frequency as well. So overall, it was found that an energy nutrient dense formula group did help achieve a positive nitrogen balance in as little as 2 days and promoted anabolism compared to the standard infant formula. When looking at tolerance, all tolerance results were within parameters of normal, although there was a higher volume of stool and a higher frequency of stool in the middle of that period. However, it did not reach intolerable parameters. And then, of course, again, it was found to be safe for patients with congenital heart disease. Right, so the next study that we'll look at asks the question, should high energy infant formula be given at full strength from its first day of usage? So for those of you on this meeting that work with the pediatric population, especially infants, I would venture to say that nobody is going straight from 20 to 30 calories per ounce within 1 day for your infants whenever you're concentrating and fortifying. And for good reason. We know that concentrating up to 30 calories per ounce has a high osmolality, can oftentimes lead to intolerance. And so for that reason, we run into the step-up, slow-down dilemma where we're slowly increasing the volume of feeds or we're slowly increasing the caloric density in order to avoid intolerance. But in this case, we have a formula that was designed to be 30 calories per ounce. And so this group of researchers wanted to know, now that we have something designed to be 30 calories per ounce, can we go ahead and provide it at full strength on the first day of usage? This was a randomized, non-blinded controlled trial that lasted for a 2-week period of time. We had 18 infants receive the energy nutrient dense formula at full strength on day 1. And the control group received the exact same formula. However, it was titrated up over a period of 3 days. So on day 1, it was provided at 80% strength or 24 calories per ounce. Day 2, 90% strength, 27 calories per ounce. And day 3, 100% strength at 30 calories per ounce. There were 30 infants that participated in this study that were fed orally or enterally, and 93% of them were on a standard infant formula of 20 calories per ounce prior to transitioning to the energy nutrient dense formula. These infants were all under 1 year of age with a diagnosis of failure to thrive. And you can see in the figure on the right that the majority of these patients had congenital heart disease, followed by neurological conditions, respiratory conditions. We also had a few oncology and GI patients participating in this study as well. So when looking at tolerance outcomes, comparing the full strength versus the stepwise group, we did see on days 1 and 2 combined that there was a significantly higher number of stools per day in the full strength group. However, at days 3 and 4, we see that there is no difference between the two groups as far as the number of stools per day. And then when looking at emesis per day, there was no difference between the two groups at any point in time. And this graph breaks it down a little bit further. So this is looking at the total number of stools on days 1 and 2. So on the x-axis, we have the patient's age in weeks. And on the y-axis, we have the total number of stools for these 2 days. And so you can see for the younger infants, there's a greater difference between the two groups as far as the total number of stools. And as these infants age, there's less of a difference in those first couple of days. And so for that reason, researchers concluded that for patients greater than 12 weeks of age, it is appropriate to do a full strength transition on day 1. However, for infants less than 12 weeks of age, it is something to consider as far as doing a gradual introduction to this type of formula in order to avoid the increased frequency in stools. And then again, as other studies have shown, this was found to be safe. All right, so now we will venture into the PICU population. So the title of this publication is Weight Improvement with the Use of Protein and Energy-Enriched Nutritional Formula in Infants with a Prolonged PICU Stay. This was a retrospective cohort study that lasted for a 2-week period of time. And infants in the PICU received breast milk if it was available. That was the first option, and for good reason. However, if breast milk was not available and an infant was mechanically vented and greater than 3.5 kilograms, or if they were experiencing faltering growth at the discretion of the clinician, they were placed on an energy and nutrient-dense formula. And then once their goal weight was achieved, they were then transitioned back to a standard infant formula. There were 70 infants included in this retrospective study that were fed orally or enterally and were expected to have 80% or more of their caloric intake from the study formula within a 14-day period of time. These infants ranged from 37 weeks postmenstrual age up until 12 months. And then you can see on the right, we had majority of patients there for cardiac surgery, some respiratory conditions, other cardiac causes, neurological syndromes, and then a few other surgical patients as well, including infection. So overall, when looking at the reasons why the study formula was initiated, approximately 40% were initiated due to unit protocol. Again, if they were mechanically vented and greater than 3.5 kilos with no human milk available, or at the discretion of the clinician. And then we saw an equivalent amount of patients being started on this type of formula due to insufficient growth, followed by a small number of those who were fluid restricted. Some patients were brought into the PICU already on this type of formula, and then there were a couple that were not documented. And then when looking at the reasons why the energy nutrient dense formula was discontinued, about 45% of these patients were discharged from the PICU. We saw about 20% of them reach their weight goal. Some experienced feeding intolerance. A few were weaned from the ventilator. Unfortunately, there was a patient in the study who passed away. And then there were also some reasons that were not documented. And then when looking at the nutritional intake of these patients, 64% of them were fed post-pylorically. And then when looking at the feeding strategy, 39% were fed exclusively via continuous feeds, 14% were on bolus feeds, and 47%, the majority, were receiving a combination of both continuous and bolus feeds. And looking at nutrient intake, on average, these infants consumed approximately 104 calories per kilo per day, with 2.7 grams per kilo per day of protein consumed. And looking at the change in weight for age Z-score over time, so we can see at birth, they were approximately negative 0.8. And then we saw a statistically significant difference between the weight for age Z-score at birth compared to when these infants started the study formula, which was on average at about 76 days of life. And then over an average of a 29-day period of time, we saw a significant improvement in weight for age Z-score, where they were then discontinued from the energy nutrient dense formula. And then when looking at tolerance outcomes, we see a minimal amount of patients with constipation, diarrhea, and gastric retention. There were nearly 50% of infants who had a documentation of vomiting, but it is important to keep in mind that this was any instance of vomiting throughout the study period. And so this could have been one episode of emesis within a month period, and it was still documented. And then you can see here at the top, this was the number of patients, a small number that did require an oral rehydration solution. So overall, this study found that use of an energy nutrient dense formula for patients in the PICU for a variety of reasons helped support catch-up growth, and then overall was well tolerated by this patient population. Okay, so we'll take a brief break from the research and review a case study. So this is baby girl Christina. She was admitted at Royal Alexandra Children's Hospital in the UK. And she was admitted at 4 weeks with a viral illness and was observed to be tachypnic upon admission. So they ran an ECG and found that she in fact has a ventricular septal defect, or VSD. So looking at her feeding history, she initially was breastfeeding and then was transitioned to a standard infant formula. At 4 weeks of life, her intake was pretty sporadic, but on average, her intake was approximately 110 mils per kilo per day, providing about 75 calories per kilo per day. And then at 7 weeks, due to poor feeding ability and tiring with feeds at this point, she was unable to achieve her target volume of 120 mils per kilo per day. So the team introduced an energy nutrient dense formula and placed her on an NG tube to provide feeds. So I know it's a little bit small and might be hard to see, but here we can see her growth trends for both weight, length, and head circumference. So at the bottom, you can see where her diagnosis of VSD was, where the energy nutrient dense formula was, her surgical repair. And then we can see that the energy nutrient dense formula really helped support this patient throughout that several month period to help keep her right on track and trending on a quite beautiful growth curve. And we also saw, great trends as far as length and head circumference as well. And we know that when looking at growth of an infant, that it's not just a matter of what their weight is doing. We also want to make sure that we're seeing adequate linear growth and lean body mass development and brain growth as well. Because we know that what we do in the first 1,000 days of life is so critical, not just for that period, but for later on and into adulthood as well. This can lead to improved developmental outcomes. And so ensuring that not only are we providing adequate weight gain, but that we also see appropriate trends in length and head circumference as well. So overall, this case study found that this type of formula was well tolerated for this patient with CHD. It helped support her weight gain pattern and then also maintain these growth patterns after the energy nutrient dense formula was discontinued. Right, so now we will look at a randomized comparison of a nutrient-dense formula with an energy supplemented formula for infants with faltering growth. This was a randomized controlled trial that was open label and lasted for a 6-week period of time. The 26 infants included in the intervention group received the energy and nutrient-dense formula, and the control group received an energy supplemented formula. So this formula was also 30 calories per ounce. However, they achieved it by including a glucose polymer and long-chain fatty acids to a standard infant formula. Now, it is important to note that here in the US, we more typically see the concentration of infant formula versus the addition of two different modulars. Not to say that that doesn't happen, but more often than not, we see concentrating and fortifying. However, at the time of this study and in this institution, that was the standard of care. And then this energy supplemented formula provides 1.4 grams of protein per 100 calories, or about 5.5% of energy from protein. Feeds were initiated stepwise over a period of 4 days with a target intake of 150 to 200 calories per kilo per day. Again, a little bit higher than we would typically target for now, but for the sake of the study, this is what their target intake was. So when looking at the study population, we have 49 infants, 49 infants that were included in this study, majority of them with congenital heart disease. We have some GI surgical patients. We also had cystic fibrosis patients included in this one, and then a few other diagnoses as well. So these infants were fed orally or enterally in less than 12 months of age with a diagnosis of failure to thrive. When looking at nutrient intake, the daily volume was comparable between the two groups, about 140 mils per kilo per day. However, when comparing the amount of protein intake, we saw that there was a 40% increased intake of protein in the ENDF group. And then we also have an increase in the micronutrients as well, about 14 to 42%. And so this is important because for infants requiring catch-up growth, it's not just a matter of giving them more and more calories. It's making sure that we're supporting, the entirety of the patient, looking at both their macronutrient needs and their micronutrient needs. And so oftentimes with the practice of concentrating and fortifying feeds, we're getting the calories where they need to be, but we might be, providing too many or too little of appropriate micronutrients. But with this type of